My name is Will Jones, and I'm very happy to be with you here today. Moi, c'est William. Je suis très content d'être ici avec vous tous ce matin. I actually grew up and graduated from high school in Quebec. And so it's every time I get to come back here, my family actually still lives in Quebec. And so every time I get to come back here in Canada, it's I really enjoy that. So I'm very happy to be here this morning. J'étais en Québec pour l'école secondaire et ma famille sont encore là-bas. Alors pour moi, chaque fois que je peux visiter ici en Canada, c'est vraiment quelque chose de spécial pour moi. Je vais parler en anglais maintenant après ça, mais je vais juste parler un peu en français parce qu'on parle français et anglais ici en Canada. So from here on forward, I'll be doing the rest of the introductions and everything in English. I'm not getting up to do all of the bios in French as well. But I'm happy to be here with you all this morning. First, we should acknowledge that we are gathering today on the land of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh. Also, I want to acknowledge Coast Salish peoples from Vancouver Island, who also inhabited these areas on the mainland, one of whom is here with us today. I wish to acknowledge as well that in this age of recognition and reconciliation, when we are seeing a great revitalization of First Nation culture, we are also witnessing the tragic reality that Indigenous people are the most affected by the crisis of drugs and addiction in our wider society. My hope for today is that we will be able to help advance the conversation to overcome addiction and promote recovery for all of the members of our society, and especially for the Indigenous communities in our midst. As I mentioned earlier, I spent part of my time in high school and graduating high school in Quebec. And what I saw there with substance use, from cigarettes to other drugs, just as that during that time period, graduating from high school and the first actual couple of years of college I did in Quebec as well. Among my peers was in the town of La Chute. It was a small town in Quebec, and cigarettes and smoking was such an issue in the high school and among my peers that they would have smoke breaks during the day because it was so prevalent among the youth and my peers there. After I went to the United States for undergraduate and subsequently started working in DC as a firefighter and EMT, I also saw the impact of substance use, particularly in minority communities in the U.S. I always tell people when I started working on this issue of substance abuse and use in our communities, the closest store to my house in Washington, D.C. in any direction would be a liquor store or a convenience store covered with advertisements for tobacco, alcohol, and lottery. And the reality is that many communities, disadvantaged communities in the U.S. and still here in Canada, it is often these disadvantaged communities that bear the brunt of the costs of addiction and addiction for profit companies that seek to exploit people for profit. And so that's why I'm here this morning with you all. That's why I care about this work. One last thing about me is, I've seen as a firefighter in the U.S., I worked at the third busiest firehouse in the United States. I gave out more Narcan probably than most people ever will in their lifetime because I was responding to so many incidences of drug use and opioid overdose. And so for me to be here, it's not about politics. It's not about a policy position just to talk, and why I'm proud to work here with all of you that are here. And is because of my passion to see people not to move free from the grips of addiction, to be able to live their life free as they want to in their own autonomy. And again, I've personally seen firsthand the cost of that in all communities, but especially, for example, where I lived in minority communities in the U.S. and what I experienced when I lived in a small town in La Chute, Quebec. So that's a little bit about me and why I care about this issue and why I'm here today. And I'm glad to be with you all and to hear from the speakers that are here this morning and that I'll be introducing as we move forward. I'd like now to introduce Dr. Kevin Savet. He's the president of the Foundation for Drug Policy Solutions and helped coordinate today's event. And he's also a good friend of mine. He was really, when I started digging deep into this issue, he really was an invaluable resource for me. And just as I really dug deep into what was happening behind the scenes on this issue. He is the only person who has served in the White House Drug Policy Office as political appointee for both Republican and Democrats, reflecting his nonpartisan position, more than 25-year commitment to this issue. He received his doctorate as a Marshall Scholar at Oxford University in 2007, where his research evaluated and balanced both harm reduction and other drug policy interventions. He's written 2 books, and one of them, Smokescreen, is currently being adapted as a documentary. Kevin?
So much. Oh, I need the clicker. I could just grab the clicker, that would be great. Good morning, everyone. How's everyone doing today? I hope everyone is doing well. Yes, you've traveled far. I'm originally from Southern California. This is like, next door. It's LA freeways, but I do appreciate the patience here for everybody, and with the last minute change of venue that occurred. You all really clearly wanted to be here. Maybe we were testing you a little bit, but you passed the test, which is great. I want to welcome everybody, and really I want to especially welcome our committee who has helped put this together. We have Dr. Derek Smith, who's a clinical professor emeritus at UBC, Dr. Paul Devlin, Blair Gibbs, a former UK policy advisor who's now in Vancouver, Dr. Julian Summers, John Clarides, and many, many others. I also want to thank the provincial leaders that are here or will be here. Today, we are lucky to be joined by the Assistant Deputy Minister for Mental Health and Addictions, Alexandra Butler, so thank you for being here. We will be soon, if not already, joined by the Leader of the Opposition, Kevin Falcon, as well as Leader John Rustad of BC Conservative Party. I want to thank the municipal leaders that are here, including our next speaker, which we're all very excited to hear from, thank you, including Mayor of Port Coquitlam, Brad West, the acting deputy mayor of Vancouver and a Vancouver councillor, actually the deputy mayor, not acting, Peter Meisner, and some Vancouver councillors who are with us, Mike Klassen, Brian Montague, also some Surrey councillors with us, including Linda Neese and Richmond councillor Chuck O, and several former elected officials in the audience as well from various cities who have actually done some really innovative work that I'm just learning about here today. I also want to acknowledge the Executive Director of Vancouver Coastal Health, who's also here to join us, Miranda Compton. Again, as I was saying earlier, I want to thank you for your patience and understanding here. I think the move here and kind of the chatter that's going on that we're not, obviously we can't ignore, is actually emblematic of the problem that we're facing and the problem that many of you are facing. And I've talked to, whether it's physicians at Vancouver General Hospital who, when speaking the truth, have to sometimes do so in fear if they sort of deviate from the norm, or whether it's people running recovery centers out in the islands like Bowen Island who working hard to counter sort of the mixed messaging that their youth are feeling, whether it's where I was so lucky to go up to we're going to hear later from Bill Yoakum, but I was so lucky to go up and see what he was doing in Kwat-Lelum out there with the new treatment center for Indigenous youth. I think the lack of the open dialogue is a problem, and that's kind of one of the things why we're here to try and change that. And really a lack of listening to one another, and sort of this interesting reflex that as a somewhat outsider, although I'm now I guess an insider, I'm here now, is sort of this reflex to pit sides against each other. This reflex of sort of one party versus one, harm reduction versus treatment, prevention versus recovery, yes law enforcement, no law enforcement. These false dichotomies that unfortunately have totally dominated this discussion as the body count has mounted to levels that when I saw after being here for how long I've been here and studying in this field for over 25 years, where I couldn't believe when I saw the numbers that I'm about to show you, and you're going to hear more about from our illustrious speakers today. So we've come together here at Prosper, and this is our very first meeting, so I apologize. We're going to mess up. It's clearly not perfect. We already started 45 minutes late. But we've really come here to break down these false dichotomies and in many cases dispel the cloud of fear the cloud of fear that many people working in this field and wanting to speak out are dealing with every day as they're trying to, by the way, save lives. And really promote this apparently radical idea that drug addiction is a preventable, treatable disease, and that everyone can recover, and as people in recovery love to say, live a life beyond their wildest dreams. That's what we're all about. Let me tell you what we're here not to do, lest you may have heard some things. We're not here, we're not funded by the private treatment sector. In fact, we're funded by many of you paid to get in, and we appreciate it, and I hope you're getting $99 worth of energy bites in the back. I hope you do that. We're not here to privatize healthcare. I can tell you as someone who got a $30,000 bill for a dislocated shoulder 25 years ago, and 100 OxyContins, by the way, thrown in. We're not here to do that. And as someone, and you're going to hear, we're so excited, and you need to stay till the end. Best for last, I can say, is my colleague Keith Humphreys that I've worked with for so long, and learning from him in the first year of the Obama administration, and putting together the Affordable Care Act, which ensured overnight 62 million people to get drug treatment. That had never happened before. But we're not here to promote a sort of privatization of that. We're not funded by law enforcement, nor are we here to promote the idea that we could ever arrest our way out of the drug problem. That's falling into the default dichotomist trap. Nor are we here to promote this party's agenda, that party's platform. Every leader has been personally invited, actually in person. We've been lucky to have an audience with each of the leaders in person. They know what we're doing. They have done their best to be here. We appreciate what each of them have done and what they continue to do. And we really refuse to be caught up in sort of the partisan mess that sometimes, unfortunately, this issue has been used for, frankly, on all sides. We're really here for one reason, and that reason is to help decision makers and the public navigate this complicated issue with common sense, evidence, empathy, care, toward the goal of prevention and recovery. So really, who are we? I mean, when I found myself here in Vancouver, actually here in Richmond to be, so it's pretty apropos that we're back in Richmond. This is where we came, not just for the airport. I actually lived in Richmond in the beginning. So it was a bit by design and a bit by accident 4 years ago, the day it was the day before the pandemic closed the border. In fact, our flight was the last one where the captain came on and said, anybody wanting to go skiing, you're going to have to turn around. Whistler is now closed. There was a collective groan. Again, I was not only sort of astounded by some of the numbers that we are seeing, but really, when it comes to the numbers of overdoses, I was frankly astounded that we kind of keep doing a lot of the same thing with some things on the corners that might be different, but we sort of keep doing the same thing and expect really a lot of different results. Frankly, whether that's in the province or whether that's in the country as a whole. And it seemed very clear to me that we really needed to think about systems-wide change. By the way, the last graph there showing that we are on track to outpace. So I wish I could say it went down in that year, but it didn't. And so this is, when you look at BC and Canada, we're on track to increase. I think it's very concerning, and the numbers don't lie. When you look at the way that we are here in the province compared to industrialized countries around the world, various regions around the world, whether it's the Middle East, Scandinavia, parts of Europe, and even the United States, which is traditionally, probably the most famous book in drug policy is called The American Disease, and that was by the late Dave Musto at Yale. And it was because, unfortunately, America always had this badge of being the highest, usage in the world. We actually, that gold medal has been passed over to you all. And that's not one that any of us would wear with pride. That's one that should be a wake-up call, that doing the same thing over and over again and expecting different results is something called insanity. And we need to figure out what else we can do. And then I think these numbers are pretty astounding. So the disproportionate level of the way we see overdoses here in the province versus the population is something that's alarming. The disproportionate level that we're feeling in our Indigenous communities, whether you do a qualitative sample of the downtown east side or whether you do run the numbers with people like Bill or others, is something that it should be alarming us. The impact is not just on the individual. I think we think about that a lot, but I think we're also we need to be thinking about the impact on other people, whether it's family members, whether it's children. This quote by the BC's representative for children and youth, I think says it all about kind of where we are. And, you know, obviously we've had a change in the game since the fentanyls arrived, and when we think about 2016, but it's not like there wasn't a problem before 2016. I mean, you sometimes hear a bit of a fetishization of, man, if we could only go back to the year when we had only doubled our overdoses instead of tripled prior to 2016, when we only had quote unquote clean heroin and methamphetamine. And I think we need to do better. So, what has been our response? Obviously, Vancouver pioneered something that was, in many ways, a shot heard around the world, and in many ways, a very smart, progressive way to think about drugs and to think about it in a balanced way with, obviously, the 4-pillar strategy. We're very lucky to have former Councillor Lynn Kennedy with us here today, was one of the architects of that, along with, obviously, Mayor Owen and others. But for whatever reason, we have seen the pillars, in my opinion, I guess, sort of fall apart, with the exception of pretty much one emphasis. And that is not an emphasis, that is not something that we want to say we don't need. But when you only have one pillar, it's hard for the structure to stay up. We absolutely need, let me be very clear, we need harm reduction. It has to be a part of the approach. But we have to invest in the other pillars as well, and I'm not saying that hasn't been there. We will give credit where it's due. But we have to understand we need a balance to prevent the roof from collapsing on top of our heads. I think it's abundantly clear that roof is collapsing right now when you look at the numbers. So, I mean, what is harm reduction? At its best, and I'll focus at its best, because we're optimists here, it is a philosophy or deeply held belief that we should strive to reduce the consequences of drug use, and save lives, and that so that we can get people ready to move on to the next phase of their life. But I think here, however, it's clear that it's gone way beyond that intended purpose. Something that might have been relevant in the era of AIDS as a death sentence needs some adjusting in today's world, I would say. We need new investments in awareness campaigns. I commend the current government for their recent investment in prevention and awareness. We need more of this. We need a lot more. Would have loved it, whoever was in power 15 years ago, 20 years ago, 30 years ago. But we need more of this. And we, again, will give credit where it is due. Unfortunately, though, we've also seen how terms, whether it's harm reduction or this other term you've heard in the media a lot lately, decriminalization, have been greatly misunderstood and in some ways weaponized. Again, giving credit where it's due is very, very important. But unfortunately, these things have been weaponized. And so they've been used to promote other policies, sometimes in isolation, not by everybody. There are people in the audience today that probably may disagree with 80% of what we're saying. But we're able to have that respectful discussion. Many of them I've met with in person, we've met with, and we wanted to actually have a dialogue. Today, I think we're cramming in a week's worth of content in about 4.5 hours, so that's our apologies there. But this is the beginning of the conversation, and we do want a conversation. But we've seen how these things can be weaponized. You've heard a lot about Portugal. You're going to hear more, which I'm very excited by Dr. Reeb. Portugal replaced criminal penalties. So they did. We were there when they announced this great announcement of replacing criminal penalties with an administrative process designed to get people the help that they need. But that was only one part of what they did. You could argue it was kind of a small part of what they did, because guess what? People weren't being arrested and jailed in Portugal prior to this policy in any big numbers. So that wasn't the issue. The issue was that they were going to make a massive historic investment in intervention. We don't need intensive treatment for everybody. We've heard people talk about that. I recognize people in the audience who have talked about not everybody needs the heavy intervention of treatment and the expense of that, but intervention along the way as well as treatment and recovery. They set something up called a dissuasion commission. That's the word in English translated from Portuguese. Dissuasion. The goal of dissuasion, not the goal of acceptance, not the goal of making you safe in your use, which is in many ways an oxymoron. Not in a way to perpetuate use either. They stopped public drug use. They made a very big announcement. We will be arresting people in Portugal, and they have, for public drug use and sales, and we're going to go after criminal organizations. But if you need help, we're here for you. And in fact, you may not even know you need help sometimes, but we're still going to be here for you. So it was intervention, treatment alongside replacing the criminal system with an administrative system. It wasn't do whatever you want, whenever you want, wherever you want. And that is how these terms have been weaponized. So I would actually say their success lies in a word that we haven't heard a lot about, which is accountability. And it's not meant to be used in a way that's harsh or cold. It's meant to be used in a way that will get people into recovery versus a laissez-faire approach towards the human beings and their families that are affected by this. We've seen the opposite of Portugal happen in Oregon, just down the road, I guess I could say. In Oregon, unlike Portugal, they didn't make those investments. And it's not surprising then to learn that the drive to move this in Oregon wasn't led by the recovery movement. In fact, the recovery movement was dead set against it, except they didn't have $5 million to compete with the two nonprofits whose stated goal is to legalize all drugs, starting with decriminalization. So when that is how you're starting, it becomes difficult to be successful when there's very little investment in treatment. They thought they were going to fund treatment through cannabis sales, but cannabis sales have been plummeting because the price of cannabis plummets when you legalize it. And so they weren't able to come close to funding the treatment they needed. And this is where we get into this issue of terminology. Again, this issue, decriminalization. It can be confusing, sometimes by accidents, but unfortunately sometimes on purpose, by people with broader agendas. We want to talk about those agendas. We want to talk about terms clearly here, and that's why we're here. And you've heard what's happened in Oregon. I won't go through it, but it was so bad that their Democratic governor, who when running in a very tough race, actually decided to differentiate herself and say, no, I'm going to keep this, but we're going to do it better. But 2 months after she got into office, said, I have no choice but to repeal this. It is a disaster, and everyone knows it. In fact, when they did polling, especially among people of color, who often are the most affected by bad drug policy on either side. Most affected by over-policing and a sort of war on drugs approach, but also most affected by essentially a laissez-faire approach leading to a for-profit approach. Will Jones talked about that. And we only need to look at our history with tobacco, any of our legal drugs, to know what happens when you become a for-profit drug dealer that is able to be on the Canadian Stock Exchange and act in legitimacy. It usually doesn't end well. That's why actually people of color were the most up in arms about what was happening. And so they were forced to repeal it entirely. But what they did was so different than obviously what Portugal is doing. So again, that doesn't mean there isn't room for the proper use of these terms, including harm reduction. And of course we want naloxone. Again, I think Will Jones is the person in this room. There may be some competition, unfortunately, who've administered more naloxone than maybe anybody on a weekly basis. Of course people have different paths to recovery. But this dire situation we are in, I would say, is the result of a massive misunderstanding of the nature of addiction and the nature of drugs. These drugs that really cannot be considered safe any more than driving 40 kilometers over the speed limit can be considered safe. You might get away with it. You might be fine. You might not get into a car crash. You might be okay the first year that you drive recklessly. But when you look at the odds and the statistics, it doesn't look good. Some can do it without consequence sometimes, absolutely. But for a lot of people, it's down a road, no pun intended, that is not good. And the nature of addiction is a brain disease, let me be very clear, and it can be a chronic relapsing one. That's not in contrast with saying that recovery is real. It's another dichotomy we've seen. But this brain disease, unlike, let's say, dementia or another brain disease, it often responds to incentives. And that's something I think we've been afraid to talk about. I have relatives in Kerrisdale who've been here for 50 years. He just celebrated his 101st birthday, and she celebrated her 94th or 5th. I can't keep track. They'll remind me, but I can't keep track. But I can't tell them, and the 94-year-old has dementia, I can't tell her that if she remembers, some minute detail of our discussion today, I'll give her $1 million tomorrow. That's not going to really change the conversation with her, right? But addiction often does respond to incentives. I was lucky enough, and I know he's here in the audience, to speak recently with Judge Tom Gove, who led the Vancouver Community Court for so long. Incredible results, and also, of course, the twins or the drug court. We know that incentives can work. We have to set them up in a compassionate way, right? Not in a way that's overdoes it. That is like a drug court model. But it also means supportive housing. It means supportive healthcare. It means education. It means access to things that you need to live a productive life. But it can't be only a handful of people that go through it every year either. I mean, you have the same problem America has with drug courts. It's a wonderful program, but it's like a little boutique hotel, that there's like 5 in the country. Not really, but it's just, you need a scale that we don't have, and we need an investment. So we got to start thinking about what happens after the 12th time you administer Narcan to somebody. It's great that you've done that. You should do that. Keep them alive. Get them what they need. Meet people where they're at, absolutely. But what do we do afterwards? And that is something we need to think about. Capacity. It's very easy to say, let's make drug court times 1,000, but if you don't have anywhere for them to go, good luck. It's very easy to say we want to do intervention. If you don't have that warm handoff, good luck. So I'm not saying any of this is easy. It's not. It's hard. It certainly doesn't fit on a bumper sticker, and probably won't fit in a campaign platform. But it's something that we need to think about. So recovery is real. Our friends at the former Canadian Center on Substance Use now changed their name recently. But what they have found when they interview people is that recovery is real, and we must believe in people's potential. People want to enter recovery, and so it has good outcomes. And I think sometimes we've led with the idea that people don't usually recover. And so we've started somewhere in a pretty hopeless state. That's a problem. We're not going to get success that way. We're not going to get success when we say, you might be able to recover from this type of disease, but not from that substance use disorder, because it's too difficult. I don't think it's too difficult. And the tens of millions of people living in recovery, including from fentanyl, will tell you that it was hard, but that it's possible. So the reality is, I would say the majority of people can do this. Most people can stop, of course, though some can't. Most kids won't start using drugs, but though some might. And most people can and do quit with incentives, though some might find it difficult. It's not even, like I said, the majority of people that will need treatment. We need to think about all the wraparound that's needed. We need to think about how to intervene productively. What does a warm handoff really mean? Well, you got to have things in place for that warm handoff when you're waiting for people to get into treatment. It's complex. But right now we have to start thinking of the problem that way as opposed to this simple problem. So I think in some ways our policies, and it's not just in Canada, it's not just in BC, but they're underpinned by the assumption that it's too late and there's nothing we can do. And I think it's that kind of hopelessness that is part of the cycle that it almost seems impossible to break from here when you just see the numbers every year. But we are here to say we want to be part of the conversation. We want to be around the table. We want to learn. But we're here to say that there is hope. People can and will recover. Yes, some people will start to use and it will be incredibly hard, but we cannot give up hope on them. So I think the big picture message is, I'll go back to that, but the big picture message is that of course we meet people where they're at, and they're going to be in different places, but we should never be content with leaving them where they're at. That is what this is about. So together with those impacted by addiction joining us as our strength, we think we can help create a world of recovery where it's the norm, not the exception, where our fellow community members thrive. You just look at the criminal justice system in and of itself, 70% of people there, not there for a drug crime, there for a property crime, there for other crimes, have some kind of substance use disorder. That is a low-hanging fruit population that you have a captive audience to intervene on. Why aren't we doing a better job at that? Dr. Humphreys may talk about this later. He and Blair Gibbs, they helped pioneer the intractable problem of what they call drink driving in the UK, where it's such a part of the culture, but they did so by, believe it or not, exporting and changing a bit of the culture. A small program in South Dakota that was having so many good outcomes, it was becoming a national model for the Obama administration. And being able to do that in the UK in such a different culture, right? South Dakota and South London, literally, a little bit different. But they adapted it and did it in a way using these principles that us as human beings can all identify with. So that's what we need to do. But when we lean on these lazy dichotomies, intense police involvement or none at all, a lot of treatment, none at all, we get bad outcomes. And so I think the good news is, there's a lot of good news. Part of the good news is there are things that work, and we're going to be highlighting that. We're not here to beat up on each other about what hasn't worked and then not have solutions. So I'm hoping today we're going to hear about solutions. The good news is British Columbians want to change. In fact, we're releasing, one of the first things we've ever done is this poll today of about 800 people in BC that shows that people actually, they want something different. They want something better. These are people across every single political spectrum, every age, and representative neighborhood and backgrounds. People are wanting something different. They are believing in recovery as the primary goal. It's not the only goal. It's not the only thing we can do. It's the primary goal. And they see this as a huge issue. In fact, they see this as the number one issue that decision makers need to fix, higher than housing, if you can believe it, higher than other issues. And so, we want to be here, again, understanding and being humble as well, that this has to do with a whole society. Adding a new drug court in your community isn't going to solve the problem overnight forever. It's part of it, but there's so much else. So we need to start thinking, I think, in a little more sophisticated way, in a little bit more of a hopeful way, and in a way that we actually know what can work for a lot of people. It won't work for everyone, but that should not stop us. And we should demand that we bring this to scale. So without further ado, I am very excited to announce our next guest, our next speaker, Port Coquitlam Mayor Brad West. I read about Brad's work on this issue, as many of you I think have, and after meeting with him could really tell that he was in this for the right reason, as somebody to break barriers, as somebody not confined by institutions of old that frankly have served us pretty badly and are killing people. And that he was really in this for the right reasons, to find answers and promote safe and healthy communities. So, when I read that he got the most votes than any mayor in his city, when I read that he was the only one ever to be reelected, it was pretty easy to see why. So without further ado, Brad, and thank you all for being here today. Thanks a lot. Appreciate it. That's great. Thank you. Thanks.
Well, thank you very much for that warm welcome. It is a real pleasure to join you this morning to speak about one of the most consequential issues facing our province, and indeed well beyond. I want to thank Kevin and his team for the significant work that they've done to bring this event together, and congratulate them on the launch of the Policy Roundtable on Substance Prevention, Education, and Recovery. I also want to thank the organizers for my strategic seat between Mr. Falcon and Mr. Rustin. I appreciate that. We're often told that timing is everything, and timing of this initiative cannot be better, because British Columbia is in desperate need of a response to the death and misery that's being unleashed upon our people and our communities by fentanyl and other drugs. And that response needs to be based in reality, not ideology. Now, I say fentanyl because I think it's important that we name our enemy. Fentanyl. Over 40 times more powerful than heroin. 100 times more powerful than morphine. A drug that very few people can name just 10 years ago, but today is responsible for the vast majority of drug-related deaths, not just in this province, but in North America. This time last year, I was one of 3 mayors in Canada, the United States, and Mexico to be invited to meet with U.S. Secretary of State Antony Blinken to discuss fentanyl and the heavy toll it's taking on our citizens, particularly in working-class families and communities like the one I was raised in and am proud to represent, and whose concerns are my primary cause. Secretary Blinken wanted to hear directly from mayors about what we're seeing on the ground, and he was especially interested in Metro Vancouver because of our regrettable distinction as being an epicenter for not only death from drugs,
but as a hotbed for the web of bad actors that are part and parcel of it. The transnational organized crime groups, the drug traffickers, the money laundering, and all those who seek to prey on and profit off the people of British Columbia. We discussed the reality of the time that we're living in. A time when an individual who thinks that they're using almost any other drug are almost assuredly putting themselves at considerable risk of taking fentanyl, as the dealers seek to increase their profit and further the addiction by cutting it into heroin, cocaine, meth, and much more. But most importantly, we discussed this. 2,511. Not numbers, not statistics, but people. That's how many people were killed by drugs last year in BC, which was more than the year before that, and more than the year before that, and more than the year before that. So what is the response to a problem of such profound magnitude and consequence? Surely, it's to ramp up our efforts, first around prevention and education, as a first line of defense to stop more people from going down this path. In the same way I educate my own 2 young children about the dangers of the world, not born out of some naive belief that I can stop anything bad from happening, but because I have a duty to inform and educate so they can protect themselves. Surely, it's stemming the tide of this fentanyl poison from entering our province by securing our ports of entry and undoing the historic stupidity of leaving our ports without a dedicated police force. Surely, it's going after the drug traffickers and the transnational crime organizations by strengthening our laws, our sentencing, and making their lives a living hell in the same manner that they have done to so many of our fellow citizens. And surely, it's by supporting those afflicted by addiction with care, compassion, resources, treatment, all leading to a goal of recovery. No? Okay. Well, how about instead we legalize possessions of personal amounts of fentanyl, crack, heroin, meth, ecstasy, and see how that goes instead? We know where it goes, don't we? Increased public drug use in some of the most sensitive areas, increased public disorder, with the public being told that their objections further stigma, and worst and most damning of all, increased death from drugs. The very outcome that many experts and activists claimed with much fanfare would be reduced when decriminalization was announced in 2022. As the predictable consequences of this decision played out, and I say predictable because it's clear that that's what it was. I've heard some commentators and apologists say, well, if we only knew that this was going to happen, we would have done it differently, or maybe not at all. They suggest, straight-faced, hoping the public doesn't know how to use Google and can't search Portland, Oregon. I digress because the consequences that played out here, the response from government to all of this was predictable. So what happened next? Well, those who are so wedded ideologically to this so-called experiment followed another predictable path. First was to deny. Deny there's a problem. There's no data. It's anecdotal. It's exaggerated. Or as Orwell reminds us, reject the evidence of your eyes and ears. Now, I must tell you that in the city that I'm honored to lead as mayor, we took a different approach. When the province's decision left no legal mechanism to stop the use of drugs in parks, playgrounds, and places where families and children gather, we stepped in. Port Coquitlam City Council was the first in Metro Vancouver to pass a bylaw shortly after decriminalization that said, in our community, this is still prohibited. And in doing so, we provided our bylaw officers the legality to deal with situations that are simply not tolerable. And by the way, we didn't wait for months or a year. We didn't wait until we had dozens of incidences. We acted immediately the first time it became clear that someone had to do something. It was a 9-year-old's birthday party in one of our premier parks. And the parents encountered an individual using drugs near the children's playground. They politely asked if the person could not do that here, and were told to F off. They called the police, who informed them that they no longer had the power to compel that individual to leave. The next day they called me, and the next city council meeting we passed a bylaw, because I was not going to accept that reality for my community, despite one commentator suggesting that it was a great teachable moment for the kids. Now, after deny, the second response was to denigrate. Denigrate those who spoke up, who identified problems, who reported the facts and the stories that bucked the party line and spoke to truth, spoke to reality, and spoke to the need for a different approach. And I must say, there are many of those people in this room today, and I want to recognize their efforts because I believe they were critical in the subsequent change in position of the government, and I think they'll continue to be critical in the work that remains to be done. Next was to delay, we're gathering input from municipalities, and then to deflect, we've struck a task force to look at the issue, just wait for its findings. But finally, after the public raised their voice to a level that could not be ignored, they relented to a degree. Despite reversing course on some elements of decriminalization, the overall response to drug deaths remained grossly inadequate and wrong-headed. And don't for a second think that there aren't a chorus of voices both inside of government and out who don't want to return to where we were a few short months ago. In fact, for some of them, their desire is to go much further with even less restrictions. Now, there are many good and well-intentioned people who I happen to disagree with on this issue, and that's okay. But my biggest objection to the approach that they prescribe is that it's defeatist. It aims low. It resigns the people who desperately need support and help to being permanently in the clutches of addiction. It cloaks itself in the veil of compassion, but delivers no change. Because recovery is possible. I've seen it with family members, and I've seen it with friends. Recovery is possible, and recovery must be the primary goal. For every person, that may look different. The path may take longer with twists and turns and setbacks and comebacks. But our response, our policies, our system, and our government must have recovery as the primary goal. I was speaking to my stepbrother recently, who is in recovery after an opioid addiction took him from the cusp of the NHL to the downtown east side, and then to jail. He now dedicates his life to speaking about his journey to young people. He called me up because he read a quote from a government minister that said, "The goal of decriminalizing drugs is to reduce the stigma that prevents people from reaching out for help." He said to me, "Brad, what stopped me from getting help wasn't stigma from drugs being illegal. It was a 16-week wait for the type of treatment that I needed. That's what stopped me. We have a long way to go, but we have a lot going for us. We have many good people who know that better is possible and want to be a part of making it happen. The public is with us. Tragically, there are fewer and fewer families in this province who are untouched by the harms of drugs. And I believe the public is more than ready to support a response that is fulsome, comprehensive, based in reality, and that includes supporting the required investment of taxpayer dollars to deliver what's needed. And finally, I would say to you that there are moments in time when we are called to confront the threats that gnaw at the foundations of our society. And this is such a time. Fentanyl is killing our people. It's devastating families, destroying lives, and enriching predators. And it will not stop unless it is confronted and ultimately defeated. I, for one, am ready to do my part, and I thank you for doing yours. Thank you very much for having me.
Thank you. As we continue to move through this schedule, I just want to let everyone know, feel free at any time if you need to take a break, use the restrooms or get more coffee or something else like that, do so. We have a schedule. We got started a little bit late, and so we're just going to continue to go throughout the schedule, but feel free at any time to take care of your needs, and we're going to make it through this day together. Our next speaker is Dr. Julian Sommers. Dr. Julian Sommers is a licensed clinical psychologist and specialist in addiction. He is a distinguished SFU professor. His career in clinical practice and research spans 37 years and includes innovations in harm reduction and recovery across the lifespans. Dr. Sommers has designed and led major initiatives addressing addiction in urban, rural, and remote communities and among high-risk populations, including youth, people experiencing homelessness, and people who are involved with courts and corrections. Dr. Sommers?
Wow, what a pleasure to be here. Thank you, Kevin, for inviting me to coffee whenever that was, a year and a bit ago, and start chatting about how we could potentially find a path forward. It didn't always feel as though progress was possible, but more and more, my feeling of optimism feels well placed. Optimism can often be irrational. It seems it's a propensity toward hope, despite evidence. It's so as a scientist, it's an admitted area of my own life where science doesn't seem to fully explain my own outlook. But I'm going to focus my remarks on science. And what I mean by that is evidence. And I've had the tremendous blessing now to have worked in BC in the area of addiction formally since 1987. I started off in Mayor West's backyard at Riverview Hospital, where it was explained to me we were in the process of deinstitutionalizing. The commitment made to British Columbians was that we would provide care closer to home. So keep in mind that this is in the 1980s. We already had compelling evidence, not only in BC, but around the world, that effective models of supporting people in communities were superior overall to the former model of institutionalizing them. And it is, I think, to our collective shame that we are here all these decades later still not having fulfilled that commitment. As the Vancouver Police Department memorably titled one of their reports as they observed the surge and change in the nature of policing in the aughts. In 2007, their report was titled Lost in Transition. They were referring specifically to this gap. So I'm going to remind us of the opportunities that we have to finally do a far more compelling job closing that gap, but other things as well, some of which have been mentioned. I want to credit a couple of people who've had a huge influence on my life, because looking back, they're responsible for some of the consistencies in my own work. The first is my first of two major influences, Bruce Alexander. And Bruce had primarily done research with animals. He was his mentor was Harry Harlow, another famous ethologist who worked mainly with primates, and Bruce worked with rats. But the studies that he was doing when I joined him involved the demonstration that rats in isolation had a much stronger preference for a morphine solution than rats that were living amongst other rats. The social component. The effect was so strong that rats that became dependent on morphine living in isolation would reverse that when placed in amongst other rats. That's the first. Second is my mentor, Alan Marlatt. And while I was working with Alan, he was absolutely smitten by some practices that he had observed recently on sabbatical in Europe that were loosely termed harm reduction. When he came back to Seattle, our next project was to apply these lessons and eventually, under his leadership, assembling a number of papers, a number of experiments, and the first book titled Harm Reduction. Several years later, I had the incredible gift, blessing, to put together major lessons that I had gleaned from Bruce and Alan. And what we had the chance to do with funding from taxpayers was engage people mainly living in the downtown east side of Vancouver, 500, who collectively, on average, had been homeless about 10 years, struggling with profound addictions, alongside other serious mental illnesses, so concurrent mental illnesses, most commonly schizophrenia and bipolar disorder. And we went up to them with our metaphorical harm reduction backpack. But it wasn't restricted to a particular thing. Many people associate harm reduction with certain practices. Oh, you mean a consumption site? Or, oh, you mean needle exchange? No, that's not what we mean. Harm reduction is applicable to all manner of substances as a practice, but it's also applicable to all manner of harms. So if someone is homeless, unemployed, disconnected from a healthy social group, repeatedly arrested, incarcerated, those can all be viewed as harms. So what would we want in our backpack if we're going to go up to someone and practice harm reduction? The consistent elements of harm reduction are non-judgment, non-coercion, a belief in people, a belief in the wisdom of people that's deeper than their conscious knowledge, but their wisdom to choose things that would lead toward greater health. So we offered them choices of housing. We offered them support regaining employment. And 100% of the people who we offered housing to accepted housing. And not one elected housing in the neighborhood where we met them. We couldn't predict where they would choose to live. There were no calamities. There was no NIMBY backlash. And the results were profound. People that were randomized to usual care tended not to receive any meaningful support. They tended to remain homeless. And compared to people who we offered supports to that they chose, the level of crime was 71% higher in usual care. Medical emergencies were twice as frequent. Costs are about the same, costs to taxpayers. We didn't need to create a giant system. Instead, we spoke to landlords, we spoke to employers. This is part of the evidence base that we now need to draw upon much more fully. But it was my opportunity to experience that what Bruce had demonstrated among rats and that had been documented in many, many other studies to that point was applicable in the form of interventions that we can mount in Vancouver. We did the same thing, by the way, in Winnipeg, in Montreal, in Toronto, and in Moncton, replicated subsequently in 4 French cities. These results are incredibly robust. Something else we learned working with those 500 individuals is that they did not become homeless in Vancouver. Their crises started further afield in communities around BC. Now, I'm going to jump to a series of things that we can do. An unfortunate experience I've had recently. I mean, it's good that I got to a certain age and stage of life before I somehow put my foot in it, raising the wrong recommendations with the wrong group, and paid a price. I paid a personal price, but British Columbians paid a much greater price, and I'll get into that. But the briefing that I gave was based on an immense volume of evidence, and one of the strengths we have in BC, which for about 20 years existed in the form of a linked information system spanning health, justice, so the 2 justice ministries, and all of our social programs. The focus of this work was to understand where people are experiencing addictions and what's working to help attenuate the problems related to their addictions and what's not working. Because it was clear in the minds of the officials that helped start this database, it was clear to them as insiders in government that in some cases, government services were part of the problem and making things worse. And Mayor West's remarks go over how that has played out or is playing out right now. To their credit, when they learned about programs that were not working well, they terminated them. And that gave me a huge amount of respect and belief in the rightness of what we were doing. Years later, I got a very different reaction, and that's kind of what I'm getting to. So I gave a briefing that involved where things are in BC. That's something I was asked to talk about. And so I made a few observations, all based on these data. Number 1, involuntarily intervening in the lives of people with addiction has been going up in BC markedly for about a decade. In about a 6-year period, involuntary hospitalizations for addiction more than doubled. During the same period of time, the proportion of our custody population, we have a maximum capacity of about 11,000 individuals per year can be locked up in BC, remanded or sentenced. The percentage of that group that had been previously diagnosed with addiction rose by 20% during the same period that the involuntary hospitalizations were going up. One takeaway from this is, let's not fool ourselves that we can afford to have a debate about whether to involuntarily intervene or not. We are already doing that. The question is whether we will do it effectively, and rest assured we're not. So I made this observation. I made the observation that scattered housing, dispersed in healthy communities, is overwhelmingly what people who are in dire straits prefer and will choose when given that choice. And it is the health, the social health of our communities that is the primary source of improved wellness. not the care of professionals, not merely having a home or a roof over one's head. And I think that's true for all of us. What confers health and meaning in our lives? It's the people that we have the ability to interact with. It's no less true for people who happen to have been homeless and struggle with addictions and mental illness. So I told them those things. I told them that we had the ability, using this province-wide system of data, to evaluate the outcomes of new investments made in an effort to improve the lives of people who are currently at risk. And I recommended that we should do that, but it's not my choice to do that, or it's not my decision, but I made that recommendation. I didn't know at the time I made these remarks to this committee of deputies that they had already approved through Treasury Board expenditures for interventions that were on the list of things that I recommended not doing. I found that out months later. But what I found out 1 week later, on Friday afternoon, was that we had been ordered to destroy the entire database immediately. We were in the process of renewing it. We had signed documents to renew it. And then the government clumsily put their foot in it by saying we were planning to sunset the database anyway. No. So this was a particularly regrettable experience for me and for people I work with. It was a catalyst for me to find something else to do besides research for a while. So I made a somewhat clumsy, at least initially, shift to social media. I'm not sure I'm out of the clumsy stage yet. It's been about 1.5 years. But I'm getting better, I think. In any case, I had to find other things to do. So here's in a little bit more detail, some of the things that we can do that are well supported by evidence internationally. We don't need to come up with some new invention here. We can apply things that have worked internationally and here. The first is to scale up community-based housing. Allow people more opportunities to benefit from the strength of healthy communities, and in a kind of obvious way, separation from lives surrounded by drug use, predation, boredom. Support regaining work. More than 2/3 of the people that we're losing to poisonings are unemployed and have been unemployed, and they're young. So for most of my remarks, I want to emphasize, using the familiar river metaphor of people falling into the river, that there is an immense need for upstream interventions, prevention, stop people falling into the river. We can't have an ongoing death crisis unless we are continuously putting new people at risk. Where is our prevention strategy? We don't hear about it. I'm not going to make too many remarks about prevention, though, because most of my career has been focused on how do we help people get out of the river. So let me stick with that part of it. I'll also add that the river metaphor is apt for BC, in that why are so many people falling in the first place? And BC has always had the highest prevalence rate of addictions, as long as records have been kept, in Canada, going back to the 1950s. One way of thinking about it is, if you go for a walk in a European city next to the river, it's likely going to be well buttressed, made from stone, and will be protected against innocently or unintentionally falling into the river. Here in the relative Wild West, the banks of the river aren't buttressed in the same way. They're grassy and muddy and beautiful, but we're a young society, and we lack many of the things that protect people against addiction. If we have strong families, strong communities, strong homes, count ourselves lucky. But the people who are most at risk, that group of 500 people that we learned with, didn't have that experience. Fully 1/4 grew up in foster care. All had profound experiences of adversity in childhood and adolescence. So our novelty as a society is one of our weaknesses. It doesn't condemn us. We can overcome it, but it's one of the sources of vulnerability. So let me get back to the river. Specialized courts have been referred to, and our team had the privilege of conducting the research so far on Vancouver's Drug Treatment Court and on Judge Gove's Community Court. They achieve the same degree of positive change that our voluntary intervention achieved, and with the same people. They're meeting under different contexts, of course. We're meeting them on the street kind of between offenses, and when they're in court, they're before the judge. But when provided with the same resources, healthy housing in healthy communities, support, obtaining work and maintaining work, reconnecting with kids, fully 1/4 of the people that we worked with had kids under age 18, but they were alienated from. And when given the opportunity to reconnect, that is a powerful incentive. Kevin Sabet referred to the power of incentives. What more powerful incentive than kids and family relationships? So ramping up these programs is another thing that we can do, and it has to be done all around BC. Same with community-based housing. A third thing that we can do to make a positive difference is scale up therapeutic communities. This is likely a short-term or a time-limited need. Portugal, which has been referred to, made their dramatic turnaround in street drug use, related mortality, and infectious disease transmissions between 2000 and 2010. Yes, with dissuasion commissions, but behind them, 60 therapeutic communities. 60. These are places where individuals live together, and mainly we'll focus on two things programmatically. One is gaining experience living every day without the use of drugs. The second, which is in part to not only fill their day, but also prepare them for life afterward, is learning a vocation. And as I mentioned earlier, the people we're losing currently are unemployed and young on average. We need to think about providing them with immediate access to therapeutic communities as a choice, I'll emphasize choice throughout all my remarks, even in the context of a court program, because cultivating agency from the earliest point possible is essential in order to ensure that people are able to maintain agency over their substance use as an end. The problem of addiction is characterized by a few things, but one of which, crucially, is a loss of control, the experience of loss of control. So investing in agency is critical. We have big ground to make up, as I mentioned, on our deinstitutionalization follow-through. Riverview Hospital, the grounds now referred to as Sumiquela, can play an incredibly important role in helping us address our current crisis and also addressing that follow-through on deinstitutionalization. The metaphor of Riverview formerly, before it was closed, was that any citizen in BC that needed resources and support beyond what could be provided in their community could be directed there physically and live there, 7,000 plus. The new model of mental health that Sumiquela can help us address supports people in all those communities, but from a hub that provides expertise, training, ongoing support to practitioners in all of our communities, and if necessary, serve as a place for referral. What kind of community is that? A beautiful community. Sumikwela can help us by being an amazing community and an exemplar for supporting people with addictions and other mental illnesses in the fabric of the community, while supporting people doing the same thing everywhere in BC. We are sorely overdue in this. The province and the Coquitlam Band, whose lands are surrounding Riverview, the Riverview site, have already had discussions along these lines. It's viable. There's no chance that we're going to make a big change unless we provide province-wide support for practitioners, including education, supervision, and cultivating networks of practice that will adopt standards. A fourth thing we can do is make far better use of our existing primary care, mental illness, and addiction resources around the province. This is, for those of you that have worked in primary care reform, you'll recall big investments made across Canada between about 1998 and 2008, including investments in BC. So I had the privilege of leading a couple of large projects demonstrating that with very little additional money, we can network primary care providers, mental illness and addiction service providers in communities around BC. I was also doing this work in the Yukon. And the level of care and the level of morale among those providers increases immensely. Right now, we're not doing that. And the level of burnout and frustration among people working in isolation is profound and needless. A fifth thing we can do is measurement. We have to get back to measurement and transparency. The track record of the current provincial government has been as bad as any that I've seen on this front in my 20 plus years working with this provincial government. Apart from my own experience and being ordered to destroy our database, the Auditor General specifically critiqued the government twice on a lack of transparency, a lack of measurement. So we need to, in my view, rebuild the system, the data system that we already had in place so that we can use the same metrics to measure how we're doing today and compare them against results that have been shown to be achievable. So these are all things that we can be doing that address long-standing debts. We should have, it, as Kevin said earlier, we should have immense optimism and hope for people that we see struggling, but we should have hope in ourselves too. And those two go together. People are not going to get well unless we believe and understand our ability throughout BC in all of our communities to make a space and allow new neighbors to be part of our communities. The results are clear. So I'm going to end with that. I have mixed feelings, about how we've got to this place. It's been a bad few years, I have to say. But I'm profoundly grateful to see your faces, people that I agree with, I know, people that I've had disagreements with, I know. But I hope you'll join me in feeling a sense of warmth that we are at last in a room together, talking about making a better place, free of judgment and blame, looking out our windshield, not necessarily in the rearview mirror. We have immense, immense strengths. And I hope we can continue this discussion and put some of them into better action. Thank you. Will, can we ask no questions?
Unfortunately, just because of time constraints, we don't have time for questions. Although, of course, the purpose of having a meeting like this, a gathering like this, is for us to network. And so I would encourage you, even if you have to take a little sidebar conversation right now based on something, go ahead and do that. I think that's perfectly appropriate. That's why we're here. But we do not have time to have a question and answer at large. Next up, we have Dr. Puya Azar. Dr. Puya Azar is the medical manager of the Complex Pain and Addiction Services, a consult service under the Department of Psychiatry at Vancouver Coastal Health, which provides management of pain, mental health disorders, and substance use disorders across all clinical services at Vancouver General Hospital, UBC Hospital, and GF Strong Rehabilitation Center. He's also the addiction lead at Foundry Vancouver Granville, which is a community youth clinic providing access to low barrier mental health and substance use supports, a consulting physician for psychiatry and addiction medicine at British Columbia Center of Excellence in HIV/AIDS, a physician for the Vancouver General Hospital Transitional Pain Clinic, and a clinical faculty member at the University of British Columbia. Dr. Puya.
You know, it's always humbling to speak after Lynette Reeve. She was one of my mentors and teachers, and somehow it seems like whenever I present at a conference, I'm going after her. So, but I'll do my best. I'll keep this pretty quick. I think it's important for me to demonstrate the profound suffering that many of our patients experience, living under the circumstances that Justin was living under, but also the complexity of our patients when we see them as care providers. So here's Justin, an individual who's presented to a hospital with the largest bone in his body broken. He needs surgery. He's physiologically dependent and addicted to opioids. So he's in severe withdrawal and has severe pain. And the molecule that we would use to treat his pain is the one that he's addicted to. He's also using methamphetamine at this time, so he's psychotic and extremely agitated. On top of all of that, he's homeless in Vancouver's downtown east side. But how did Justin get here? He was in many ways just like the kid next door. He lived in the suburbs, fantastic soccer player, excellent student. His goal was to go to the US with a soccer scholarship. He developed a knee injury, needed surgery. Was started on oxycodone by his physician for pain. And it had two effects for him. The first one, it took the pain away. Secondly, although Justin was confident and a popular kid, he suffered with anxiety, and it took the anxiety away as well. And when he could no longer access the prescription that he was provided, he decided to use, or he resorted to using unregulated opioids. He spiraled very quickly. He ended up in Vancouver's downtown east side within a year. And it wasn't until he fell down those stairs that I was able to treat him in hospital. Now, a little bit about my work. I'm a psychiatrist, addiction medicine specialist, and about half of my work is spent doing research. And all of my research is spent on solving clinical problems that we see in people who use fentanyl. And we've been pretty successful. We've been able to publish a number of papers. And our protocols are now being used in the United States and other parts of the world in hundreds of hospitals to treat people who use fentanyl. And we've been very sophisticated with our research to the point where we're now able, using our protocols, to get anybody who's using any amount of fentanyl off of fentanyl onto opioid agonist therapy within about 24 hours in hospital. We do it all the time. But if it was that easy to treat people who use fentanyl, we wouldn't have statistics like this. I'm just going to allow you guys to read it for about 30 seconds. Ross had a hard time fitting in. He ended up fitting in with a group of kids who were using cannabis. And then he was offered unregulated oxycodone, didn't know what it was, started using it, liked the feeling, and he tells me he would never have used heroin because he had a negative view of heroin. He knew it was dangerous. He had seen it in the movies, but oxycodone seemed safe to him. And very rapidly got hooked onto oxycodone, ended up going on to heroin, and then fentanyl. And it wasn't until I met him in the emergency department that we were able to have these discussions. And now he's on opioid agonist therapy and doing actually very well. But he did spend several years homeless in Vancouver's downtown east side. Both of these individuals didn't know where to seek help. They certainly didn't enjoy living homeless in Vancouver's downtown east side. They wanted abstinence. They often went into hospital for various conditions, often skin infections. They were detoxed or placed onto opioid agonist therapy in hospital, but then they had nowhere to go. And they ended up going right back to the circumstance that was perpetuating their use. So I can tell you that no amount of opioid agonist therapy, methadone, sustained release oral morphine, buprenorphine is going to help this individual to stop using, because all of his attachments, and perhaps the most important attachment of his life, which is his relationship with his mom, depends on using fentanyl. So every single person in his life that he's connected with, that he sees on a day-to-day basis, uses fentanyl. And it's omnipresent in his environment. So he tells me as soon as he wakes up, he goes out of the room in his SRO and he encounters fentanyl. He sees his friends, they offer fentanyl. He goes to visit his mom, she's using fentanyl. Again, he had come through hospital multiple times, and it's not rocket science to rotate him onto opioid agonist therapy. But we're sending him right back into the circumstance, which is perpetuating his use once again. And that attachment piece is extremely important, because for him to stop using may mean that he would have to sever those important attachments, including the one with his mom. So that's profound. He told me that fentanyl loves him. So again, the offer was there to detox him, put him onto agonist therapy. But I think we have to be careful, and we can't oversimplify addiction, and we can't get too wrapped up into pharmacology, although almost all of my research is on pharmacology. And we have to understand addiction for what it is, and the complexity, and the fact that if we don't treat all the underlying factors that drive addiction, mental illness, social determinants, relationships, etc., I'm not sure if we're going to find our way out of this overdose crisis. And unfortunately, many of my patients fall into this revolving door where they come into hospital, they receive excellent treatment, and we put them right back into that circumstances. In some ways, for me, it's analogous to treating somebody with a gambling addiction in a facility and then discharging them right into a casino and saying good luck. This narrative that it's untreatable, opioid addiction, I don't subscribe to. I think we can have hope. I think we have to be sophisticated and holistic with our approach. I think we do have to be sophisticated with the pharmacology, but we can't forget that it's a complex condition. And we can't forget about the psychosocial and underlying mental health factors that often drive people's addiction. So I think that's my take-home message for today. Thank you.
Thank you so much for sharing that in the videos. I love how you incorporated that. I always feel like seeing people's stories is one of the most powerful ways that we can learn as we hear other people's experiences, and just seeing it visually represented in videos is something that's very powerful. So I appreciate you sharing that. And next we have someone who shares my name, actually, William, or Bill Yoakum. And he's in the field of child and family services for Indigenous youth and families on Vancouver Island. Bill Yoakum is a transformative leader. Having dealt with trauma in his own life, Bill understands the importance of providing an environment required for children and their families to overcome barriers. At Kw'met-Lelum Child and Family Services, Bill has been the executive director for 16 years, and under his leadership, the agency has helped children and families in 9 First Nations as well as urban centers. This has involved the development of cutting-edge programs and policies that are informed by Big House teachings, which ensure all First Nations youth be cared for and served. Bill helped found the Orca-Lelum Youth Wellness Center in Lanceville, which is the first in the province to offer detox services specifically for Indigenous youth. Bill?
Good morning, Hysepka, Skulitzelton, Billy Oakham. It's an honor to be here in front of such amazing speakers, doctors, amazing people with the common goal of bettering a society. I'd like to first of all thank the Coast Salish people of Musqueam and neighbors where we are doing this hard but amazing work this morning. I just gotta take a deep breath here. Sorry, this is a heavy stuff and hits home for a lot of us. And this is a nonpartisan event. I got to wear my professional hat. I'm also elected councillor at Snail since 2002, served one term, and I did not have a positive encounter on our table, so I'm just trying to regroup with the individual that was, I can't even say his name. And anyway, so I'm just trying to regroup. Kevin, I apologize. This isn't about me or what's this event. I mean, what this on the table. I got to challenge myself. Everyone in this room has different views. And I got to challenge myself when certain views just do not align. What we're trying to do here is better society. And so is Andrip, and so is Haida, and all that stuff. So I've got to regroup here. So I apologize for my horrible start. I'll get back to her. Thank you, Peter. Peter, can you play a quick song? Can I please ask you, my friend? I really need to get grounded. It was horrible. Oh my God, close that door. I don't want to look at him.
Drum's a little flat, but go with it.
Thank you, Peter. That drum in his hand, ladies and gentlemen, respected guests, is medicine, and that medicine is and can be for all. Wesley George, Tricia Henneque, Arthur White, Joey Wise, Garnet White, Randy Wise, Clifton White, James Cornish, Angel Fraser, and the many others. We should have been better. We pray peace has found you. When we talk about the issues of drug and addiction, we acknowledge that we use often language that is based with fear, that expresses blame, or installs shame that labels or stigmatizes some, and at times marginalizes others. I acknowledge also when these issues are talked about, we often use the language of partisan politics, or trying to score points, or creating wedge issues, or spinning a narrative for the public. Well, I'm not interested in that, nor I think you are nor interested in that. But I think what we're all in this room are interested in is a conversation with solution and resolutions. And I'd like to thank Kevin and team for organizing a profound event that is long overdue where all stripes are going to roll up their sleeves and working together as one. Just like Peter came up here and saw a brother in a little bit of distress and brought his medicine. So that's what we have to do together as one. So let me briefly tell you a little bit about, thank you. My name is Skolitzo William Yoakum Sinemo. I'm the proud grandson of the late Eva and Alfred Wise and the son of late Ivy Wise. I've been elected member of Sinemo Chief of Council since '02, Executive Director of Kwame Lane Child Family Services, I believe Will mentioned. I lose track now. 16 years, I think you said. Time flies. But in our culture, when we talk about drugs and addiction, we adopt a language of love and care. Because we recognize that when people are struggling with drugs and addiction, it is a response to trauma and pain. I want to stress the word trauma in this conversation. There's a lot of profound speakers with much more wisdom than myself. But one thing we're going to go upstream, some folks, so you professionals, and let's talk about the trauma upstream. It is not just a healthy response. It is such a circumstance that people need to help people understand and hold on to other responses to the pain and trauma and let them choose. And also, we build supports and systems that do that. We help to provide love and care so that people feel empowered and have the courage to make a different choice. Although great political shifts have occurred at the federal and provincial level, which may have complex, interacting, and cumulative impacts on health, wellness, outcomes for Indigenous peoples, the data shows minimal direct benefit resulting from these commitments and as seen to date. Indigenous youth are dying at an alarming rate despite current health programming. Orca Lalem is a solution, or let me retract, part of a solution. Our obligation is to Indigenous youth is not just to keep them alive, but to ensure they live and thrive like mainstream rest of society. They deserve it as well. We've heard loudly from both community and youth throughout our engagement process that our community needs a local Indigenous wellness center. Drug toxicity is the leading cause of death in our province, as we all know in this room. We need to provide local treatment options to youth so they can be close to their families and receive programming which is culturally safe. There is unanimous support from the community and youth for the creation of an Indigenous Youth Wellness Center, which will offer detox and residential treatment on Vancouver Island. We believe this treatment programming, rooted in cultural activities and teachings, will provide better health outcomes for youth, and that's why we've created Orca Lalem. Currently, there's only one Indigenous-focused youth addiction treatment center in BC, and it provides services solely for Indigenous females, which is great, but obviously need more. Opening of Orca Lalem on Vancouver Island will increase the total number to 2. Youth treatment centers in the rest of Western Canada. There are a small number, 6, of Indigenous addiction treatment centers for both youth and the rest of Canada. At Orca Lalem, we wholeheartedly embrace the guiding principle of not so much Ashkolowin, meaning people working together with one heart and one mind. Our commitment is to deliver holistic programs that prioritize substance use recovery and trauma healing. We do so through distinct yet interconnected initiatives. Medically supervised detox and residential treatment, exclusively designed for youth ages 12 to 18, extending our support to their 19th birthday. Orca Lalem is dedicated to provide a safe and nurturing environment that recognizes the unique needs of our youth, rooted in Indigenous ways of being. We aim at empowering young individuals to regain their strength, resilience, cultural identity, instilling a sense of purpose and connection that extends beyond treatment. Our mission is to heal, inspire, and unite. Through collaborative efforts, we strive to foster a renewed sense of hope and well-being among our youth, strengthen them for a brighter and healthier future. At Orca Lalem, we're committed to nurturing the heart and mind, guiding our youth towards a path of recovery, but also cultural revitalization. Together, we journey towards a healthier and more empowered community. We believe that culture is medicine. It is the heart of everything we do because we know it has the power to strengthen and heal our children, families, and communities. Over this journey in the last 6-7 years, we've we've taken over the child welfare round, which we all know in this room is a horrific stat across in BC, across this country. Nevertheless, our practice and modifying our ways have totally contradicted the trend and stats that's happening across the province and country. Therefore, we believe and feel confident that Orca Leyland, following a similar model, obviously in the right professions, will have the similar results. On behalf of our chiefs, our people, and myself, we'd like to lift our hands up to Premier Eby, Minister Whiteside, Richard Jock, FNHA, for supporting the vision of Orca Leyland and helping us bring our hopes for a better tomorrow. In closing, again, I'd like to honor Wesley George, Tricia Hennique, Arthur White, Joey Wise, Garnet White, Randy Wise, Clifton White, James Cornish, Angel Fraser, and many more. We have to be better. Haisepka.
You're awesome.
Thank you. That was amazing. You did great. Thanks.
Thank you so much. Thanks, Tony. Thanks.
Bill, thank you so much for sharing that. And also, just on a personal note, the Courage to Ground coming up was something that's actually I'm going to integrate moving forward. I speak a lot, and I think just having that vulnerability and that courage is something that I should take forward if there's any instances where I think we can all incorporate this when we're in a place where we need to ground ourselves, to not be afraid or ashamed to do so. That's something that I just learned from you, and I appreciate you demonstrating that for us. Our special keynote speaker is Kevin Falcon. Kevin Falcon is the official opposition leader for the BC United Party, elected leader in February 2022. He was then elected as MLA for Vancouver, Kilchena on April 30th, 2022. Prior to this, Falcon was elected MLA for the Surrey Cloverdale in 2001, a position he held until 2013. He was born and raised on the North Shore, and he graduated from SFU and the real estate program at UBC. And just because of time, I am shortening people's bios, but I encourage you to check back in the registration or Eventbrite to read everyone's bios. Everyone's bios has been shortened, but there is so many accomplishments that each of our speakers have had here that we're having sharing this morning and this afternoon. So I encourage you to go back and check and read their entire bios. Kevin?
Thank you. Thank you. Well, thank you very much. Let me correct you. Putting accomplishments and politicians in the same sentence is not typically something that I would endorse, but nevertheless, it is a pleasure to be here. I have to tell you, listening to some of those testimonials really ground you, because you realize, as a previous speaker had said, that this isn't about statistics. Behind every statistic is a person, an individual, somebody's loved one, whether it's a child, a sibling, a parent, a friend, family, and we should never lose sight of that. I'll just tell you two quick stories about addiction. First, just one growing up. As a young child, I was one of 6 boys in a family. I remember going out to regular family events. We would all pile in the car, and my dad would always drive, and we would go off to these different family events. And we had an uncle, my dad's brother, who had a serious alcoholism addiction. And quite often when we would go to the family gathering, he wasn't there. And so my dad would pile some of us boys into the car, and we would drive around the streets looking for him. And eventually we'd find him somewhere in an alley or somewhere where he had snuck away and drank himself into a very bad state. And then my dad would get out, and I always remember as a child, just the, what's the word I'm looking for? The humiliation of listening to him yelling at his brother, saying, you know, what the hell are you doing? And you've ruined another dinner and all that kind of stuff. And then dragging him back to the car with my older brothers, helping to bring him back into the vehicle to drive him home so he could be there with his family, but his kids and his wife is upset. And it's really, really awful. And then another story, a very good friend of my wife's whose sister was struggling with addictions. and who lived alone with her daughter, young daughter. I think she was 8 or 9 at the time, and overdosed in her bathroom with the door locked while she was in the bath, and passed away while her daughter's banging on the door trying to get her mom, and then ultimately phoned the grandmother, who then sent the police over and discovered that she was no longer alive. And so I think the commonality behind these stories is that struggle of addiction. It is there's nothing worse than being a slave to addiction, and there's nothing more important than folks like you gathering here to say, what can we do differently to try and drive different results? And so I applaud all of you, and I applaud Dr. Sabat and Prosper for bringing together folks that are just seized with one thing, to put forward ideas that we can try and get different results here in British Columbia. Maybe we can find a path that the rest of the world can look at and say they're doing something different there that seems to be working. But we also have to have the intellectual integrity to say when things are not working, and to have the courage to say the emperor wears no clothes. Compassion alone is not enough. I would argue that there's compassion fatigue in much of the broader public, and that's a worry too, because we don't want people to lose compassion for those that are struggling. And so today I want to sort of talk about how I see the current landscape and what I believe needs to be done in order to drive us in a different direction. The governing philosophy of the current government is essentially this: publicly supplied addictive drugs to those struggling with addiction, because the primary goal, according to government, is to make sure that people aren't dying. And secondly, as part of their 2020 campaign platform, to accelerate the decriminalization of drugs, because they wanted to eliminate stigma associated with drug use. So let me just touch on those for a moment. I want to remind you, I've been a former health minister. I've been a business leader. And the one thing I really, really care about at the end of the day, stripping aside all the politics, is results. I think that as government or as health practitioners, we have to always follow data. Because if we try to use our own ideological assumptions to replace facts, then you end up in a bad place. And right now, the data is not good. As Brad West earlier pointed out in his speech, every single year, the overdose death rate continues to climb to the highest levels ever in the history of the province of British Columbia. Last year, again, over 3,500 individuals. Just yesterday, we find out that over the last 5 years, 126 young people have died over the last 5 years. 25 people a year with their whole life ahead of them. So those are not good results. And when you're not getting good results, I promise you one thing: if you do more of the same thing, you will not get different results. And so it's important that we look at it and say, okay, well, what can we do differently to ensure that we don't get the kind of results that we're seeing right now, where the number one death rate for those, as we saw on the screen, between 30 and 55 or whatever it was, is drug overdoses, and where it's the leading cause of death amongst young people. First of all, let's talk about decriminalization. Now, I have always said that arresting people for simple possession makes no sense. I think we can all agree on that part. In fact, the Vancouver police would often tell me, Kevin, we never arrest anyone for simple possession anyhow, maybe 10 times a year at most. And that'll be people that are either have drugs in a playground or a school or what have you, where we need to make an example. So it was really never about criminalizing people for possession of drugs. But what the NDP did when they decriminalized drugs is they took away the one tool the police did have to make sure there's some social discipline around the use of drugs, so that you didn't see what we saw, which was an explosion of open drug use in parks, playgrounds, beaches, public spaces. And that's not a good message for our children and families and neighbors and communities. And that's why people started to get very upset. And for the better part of a year, we said to this government, for God's sakes, please, you have to have guardrails around this decriminalization, or it will be a disaster. Guardrails mean making sure the treatment's in place. Guardrails mean making sure that you're sharing data so the public can see, is this experiment working? Guardrails mean making sure that you can't just have people openly using drugs on SkyTrains and in restaurants and parks and playgrounds and beaches. And for the better part of a year, I said to government, please bring in some restrictions. They wouldn't do it. And then the chorus of voices started to grow. community leaders like Brad West and others that were stepping forward and saying, well, hang on a second, this isn't working in our communities either. And finally, they said, okay, we'll bring in a piece of legislation, Bill 34. And although, frankly, it was poorly drafted and I think it had problems, it was then challenged in the courts. Now it was stuck up in the courts. Then the government said, okay, well, we're going to go back to the federal government and plead with them to bail us out of the problem of our own creation and recriminalize some portions of drug use so that we don't have the open drug use that's taken place throughout our communities. But why is this important? It's important because we have to think about what it is we're trying to achieve. When I was in government in 2001, I'm going to give you an analogy, not a perfect one, but a pretty good one. We were concerned about youth rates of smoking, and we were concerned about the 16,000 people a year that were dying from lung disease. And we said, how are we going to change that? And we made a really difficult decision. Some of you may remember this. We said no more smoking in restaurants, in public spaces, in office buildings, and on beaches and parks and all that. And I'll tell you, it was not easy. The restaurant industry came back and said, how could you do this to us? They're our best customers. Apparently there was the belief that they drank the most and, smokers were great people. But you know what happened? A lot of people came back into the restaurants, said, this is great, it's smoke-free. I don't have to go home smelling like smoke all the time. And then we said to the federal government, you need to do your bit. We need to make sure the packaging is really clear about the fact that that smoking is dangerous for our children. And we got them on board with warnings on the packages. And then we said, we're not going to allow it to be sold in gas stations. Remember, you used to be able to just go in a gas station and pull that funny lever and out came your cigarettes? And lots of kids did, right? I was a kid once. We used to. My friend used to get smokes for his dad. Some for him too. He's still smoking 40 years later, the poor guy. But the point is, it was easily available, and we changed that. Now, why did we do that? Because we started to see smoking rates going down, especially amongst young people, and the rate of death start going down. And that's what we were trying to achieve. We stigmatize smoking, admittedly. Standing outside in the cold, that's stigmatizing, right? But that's part of society's way of saying we want less of that. And that's part of our messaging to children that we don't want you to take up that because it's actually not good for your health. Now imagine if we'd taken the same approach that this government's taken with respect to drugs. Here's what we would have done. We would have said, smoke wherever you want. In here, restaurants, no problem, because we don't want you to be stigmatized. And by the way, if you're struggling with addiction, we've got some free cigarettes here. These ones are less dangerous than the ones you're smoking. You can have these ones, and we'll make them freely available. Now, of course, that's ridiculous, isn't it? Just the thought process is ridiculous. But why is it any different when it comes to drugs? I do have to ask this question. I've been asking this question to the Premier. I said to the Premier, you're currently suing Big Pharma, appropriately, for the OxyContin crisis and the other drugs that were distributed widely in a clinical setting, mind you, but addicted a whole generation of North Americans and created a huge crisis. And this government is part of many governments that are suing them for the damage caused by the fact that they were really pushing these onto doctors, saying that they were very safe, and it turned out they weren't so safe. But at the same time we're suing those same pharma companies, we're buying hydromorphone off them, Dilaudids, and we are making those freely available here in British Columbia. Does that make any sense to anyone? It doesn't to me. And I was the health minister that did the Naomi trials that said, could hydromorphone be a way that we can help transition people to treatment? Yes, it can. In a proper setting, there is a role for drug substitution to help people get to treatment. But the key part is help people get to treatment. It can't just be setting up vending machines and handing out drugs so that people are now widely spreading these drugs throughout our communities. It does not end well. It didn't with the OxyContin crisis, and it won't with the hydromorphone. And that's why I feel so strongly about this, because I think it puts our children at risk. And then we said to the government, you have to understand there's going to be diversion that takes place. Because guess what? Language matters when it comes to drugs. When you say safe supply, to us that might mean one thing. To a 14-year-old, that means an entirely different thing. When a drug dealer comes to them and says, don't worry, this is government stuff. This is safe. You don't have to worry about the fentanyl and all that stuff out there. Here's some safe supply for you. And you know what? When you're 14-year-old, your brain's not fully developed, that's pretty attractive. And that's what's been happening. And the government attacked me and us for saying this. They said, oh, you're just scaring people and misleading, and it's not true. Lots of attacks. I'm used to attacks, by the way. It's okay. But the point is, I stuck on this because I was hearing directly from physicians, addiction specialists that were saying they were mortified at what they were seeing happening in their offices. The young people presenting with opioid addictions as a result of diverted drugs. And then things slowly started to change. Suddenly we had Dr. Bonnie Henry acknowledging a few short months ago that, yes, diversion is a common occurrence. Well, that was news. First time they had acknowledged it was, why was that happening, I wondered? Well, because she had done a survey of physicians, and they were responding and saying, yes, we are seeing diversion being common. Then we saw some drug busts in Prince George, in Campbell River. And in addition to the usual heroin and cocaine and methamphetamine and all the other drugs, there were thousands and thousands of government safe supply also being captured. Why is that? Well, because guess what happens? People are taking the free drugs from government and they're selling them to dealers for cash. They're using the cash to buy the drug of choice, which sadly is often fentanyl. But what happens to those drugs that are sold back to the drug dealers? They're selling them to our kids in high schools, in colleges and universities. And we can play denial if we want, but I would argue that the evidence supports exactly that happening. And that is not a good thing. And then the Auditor General came out with 2 reports. See, now we're getting more third-party validation. The Auditor General said, government's hiding the data. They've got the data, but they're not sharing it. That should be of grave concern to all of you. And Dr. Julian Summers was up on this stage early on, and he can tell you about government hiding data and destroying data. Data that doesn't align with their ideological direction. My friends, that is not a good thing. Because at the end of the day, to deal with any challenge, especially the challenge of mental health and addiction, we have to follow data. And sometimes the data may say to you, Kev, you're wrong. What you're doing isn't working. And then we better have the courage to say, then we better change direction and try something different. But I'll tell you, when the Auditor General says there's significant deficiencies in overdose prevention and at their supervised consumption services and the entire safe supply program, and they've got data that they're not sharing, that and those are a bunch of red flags. So what is the solution? The solution cannot be bumper stickers and slogans and politicians trying to play politics with this, because I agree with the previous speaker. That is a huge risk. I can tell you that this is actually the most important issue for me, just so you know. This is the very first policy we announced as BC United, formerly the BC Liberal Party, called Better is Possible, our plan to change direction in British Columbia and deal with the challenge of addictions. And we brought that out 18 months ago. It was detailed, it was comprehensive, and we costed it out as best we could. But here's what we said. First of all, treatment should be affordable and accessible. And that means cost should never be a barrier to treatment. We will make sure there is no cost to treatment, because people shouldn't have to be mortgaging their homes, selling their vehicles to try and support their children that are struggling with addictions. Free treatment, not just free drugs. Secondly, recovery communities. We will build a minimum of 5 regional recovery communities for addiction treatment where residents can stay for up to a year with individualized, holistic, long-term residential treatment, including Indigenous-specific care that's culturally appropriate, but that can also be involved in teaching, learning, relearning life skills. Because I believe, based on the 10 years that I spent on the board of the Street to Home Foundation, working with the homelessness in the downtown east side, studying the problems, volunteering, going and visiting low barrier shelters, that many of these folks do want to give back and be productive members of society again. But you can see that the struggles that they have, the hopelessness, the trauma, the challenge of getting there. But we must do everything we can to make it accessible. And that ought to be the priority of any government, is making sure the treatment is going to be available when they are ready for it. Treatment on demand is important too. Creating a virtual opioid dependency program to ensure immediate access to life-saving medications like Suboxone or methadone for those who don't have a doctor or can't get through or into a walk-in clinic, where today we've got the longest wait times in the country. Comprehensive care, building on that model of single parent employment initiative that we brought in when we were in government, recognizing single parents need really unique supports, pay for their childcare, provide them financial support so that they can get back into the workforce. It was very, very successful. We need to do the same thing for those struggling with addiction, providing residential treatment, counseling, and job training for up to a year so that we can help them get back on a path of recovery. And even our corrections facilities. Think about this. If someone is being sent to jail for 2 years less a day, that's the provincial jails, it's an opportunity. Since they're there already, why don't we make sure there's treatment there so that we can help them when they get released back? Thank you. Released back into the community. Maybe they can release back into the community without having their ongoing addiction challenges. These are the ideas that I think can start to shift direction for us. But we also have to recognize the mental health component. And this is important. We have failed those struggling with mental health, all of us, including my government. I would say all the way back to the social credit days, when the decision, it was a North American-wide decision. It kind of swept North America to start closing down the institutions. And the idea was to provide supports for folks back in their communities. The supports were never there, or they were very fractured. And I remember when we got elected in 01, I think, it went through social credit, 10 years of NDP, and then ourselves. I think there were still 15 or 16 people at Riverview that we finished before it closed down. Now, we opened up a new facility. We started it open under the NDP called Redfish. But Redfish has 108 beds. It needs 400. And we need to have a Redfish in every community, the North, the Interior, the Kootenays, and Vancouver Island, because we got to make sure that care is closer to home. And here's the other thing, that folks that are struggling with untreated mental health that cannot make decisions in their own best interest, it is not compassionate leaving them on the streets. That is not compassion, my friends. And here's the tough part. True compassion means taking them lovingly, compassionately, and involuntarily, if necessary, off the streets and into proper 24/7 secure care with proper psychiatric and medical supports to ensure that they get the care and attention and love they need, with the goal of getting them back into the communities once they're stabilized with proper supports. That's the approach we're going to take. And that's the approach that's needed. Thank you. Because every day I look out and I see these tortured souls, how wrong is it that we pretend we're compassionate and just leave folks like that? If that was you or me, I would hope you would say, oh my God, I can't believe Falcon's out there like that. No, I'm serious. Yelling and screaming to no one in particular, a danger to himself and others. We can't leave him like that. We have to do something. And we do. And we will. And I can tell you this is especially important for young people, because young people have the best opportunity to be saved. And that means we have to get them into care, especially involuntarily if necessary, because those young people have a whole lifetime ahead of them. And our obligation as society is give them every opportunity to live a great life. And I remember when I was speaking to a chief up in Penticton, Greg, he said to me, Kevin, because I told him, I said, Chief, I know this part's controversial. And I'm always honest. I'm a very straight up person. I said, Chief, involuntary is part of my platform. Because I know with First Nations, that can be a sensitive subject. But I want you to know why I think it's important. And I explained why. And the Chief Gabriel said to me, he said, Kevin, I can walk you out of here and we can go visit our grave sites. And there's a lot of new ones. And there are a lot of our young people in those grave sites. We owe them a better duty of care. We owe all young people a better duty of care, and we're going to make sure we do that. And the other thing is homelessness. Now, we've endorsed the plan that was laid out by Dr. Julian Summers in July of 2021 that provides an effective roadmap for street homelessness with a focus on evidence-based services. That's important. There's a whole bunch of service providers out there that are not delivering very good evidence. And I can tell you this, we're going to make sure that we look at all those providers and make sure that we're focused on outcomes. And if they're not getting outcomes, and they're not prepared to change their direction so we get different outcomes, they're not going to get funding, because I'm going to fund success, not failure. And we're going to make sure that we're disciplined about that. Because if we in government are not demanding outcomes, believe me, you won't get them. I've been in government long enough to know. And whether you're in the government or the private sector, I can tell you, you have to focus on data and results. Now, I will also just say, something around that. The data I like to go on about. Julian Summers also often mentions this, but it's so important to understand something. In the private sector, we used to always say you cannot manage what you cannot measure. If you're not measuring it, you're not managing it. And right now, we've got a government that can't even tell you how many treatment beds we have available. The number keeps changing. And they confuse announcements with outcomes. Announcements, my friends, are not outcomes. Outcomes are when you have the detox beds ready available. So when that young person says, I need help, they get into a bed right away. They don't get told, we'll see you in 6 weeks on a Tuesday morning at 8:30 in some government office somewhere. They'll never be there. We have to have a more resilient system, and we will. And the final points I just want to make are this. Sentencing and rehabilitation. You know, we have to make sure that we are giving folks a choice. At that moment, when someone appears before the judge, and Judge Gove's community court's a great example, they get a choice. Door number one, your traditional incarceration. If you're there for an assault or what have you, something that requires an incarceration, door number one. Door number two, secure mandatory treatment to deal with the underlying issues of addiction, perhaps mental health, but to make sure that they have that option too, to get better and get well. But either way, we want to make sure that they've got access to treatment, and that's why having some of that in the jail system is important, because we don't want them entering back into society with unresolved addiction issues. And the second thing is pursuing civil consequences for those that traffic drugs that cause death. This is really important to me. Do you know we've got a law in place that if you overserve somebody and they leave your establishment and go cause an accident and kill somebody, they're civilly liable, and that's good. But it should be the same thing for drug dealers. When they're selling drugs that knowingly could put our lives at risk and the lives of our young people and people on the streets, then they ought to be charged for that civilly too. Sue them for everything we can and make sure they're held accountable for the damage and the deaths that they cause. But my friends, I'll conclude by saying this. Ultimately, there's no really simple solutions. Anyone that comes to you and says, I have a simple solution to a large complex problem, it's usually wrong. But what we do have to do is make sure that we know one thing, and that is we better make sure our decisions are driven by evidence and data. And I am very concerned about a government that is ignoring both evidence and data. And let me tell you something. If it's not working, you pivot. If it is working, you do more of it. But you better never give up on those that are struggling with addictions, because we owe it to them to recognize it is not a stigma. It's no different than when you break a leg. When you struggle with addiction, let's make sure they get the support they need. And never forget the success stories. And you saw some of them on the screen. Never forget those that have, in spite of our fractured, chaotic system of care, that there are those that have recovered and are struggling through the journey of recovery. Let's support them, make sure they have every tool to be successful. Thank you for joining me here today, and thank you for all the work that you do.
Thank you so much, Kevin, for sharing that. Just because everyone has been sitting for a while, I'm just going to say, take 5 seconds really quick. Everyone just stand up, get the blood circulating again, and then we'll sit back down. We have a few more speakers today. I've been coming up and down, so I've been able to be engaged. I want you guys to be able to stand up as well. All right, and now if we could sit down again. I hope that was a little bit helpful for you guys, just keeping the blood flowing. And we are now going to have Dr. Leonora Regenstreich coming up next. All right, I'm going to go ahead and introduce Dr. Lori Regenstreich. If we could just, even if we're still standing up, if we could keep the conversations down. Stretch, please, but let's keep the conversations down so that we can continue. Thank you. All right, Dr. Regenstreich is an adjunct clinical professor at McMaster, working in inner city Hamilton since 2004. Co-founder of Shelter Health Network 2005 and the Hamilton Clinic, OAT 2011. She started the St. Joseph's Hospital RAM Clinic and inpatient addiction consultation service in 2017. Youth correctional health care since 2018, mental health and addiction focused, and since 2010, focused practice in addiction medicine with special interest in care of people who use fentanyl. Dr. Lori.
Thank you. All right, so is this my remote? Is this my remote? For the slides? What do I do that? Oh, perfect. All right. Good morning. I feel like I am not the main stage, but I've had an awful lot of really excellent warm-up bands. I was asked to speak last night, so I don't have a lot of slides. I pulled a few things off my phone and gave them to our wonderful audiovisual guy. This is me in Fort Good Hope, which is in the Northwest Territories, but halfway between Yellowknife and Inuvik. And I just want to talk very briefly about the people that I most want to protect in the country and give this a little bit more of a national perspective. I work in Ontario, and I'm very lucky because a couple of times just in April, I was invited to participate in some community gatherings. They were called information sessions or community gatherings. The first one was in Sarnia, Ontario. And the reason I got all these papers is this is all my back of the napkin math that I've been doing, figuring out what the overdose death rates are in some of these areas, because I never really thought about it because I follow the provincial overdose death rates or urban overdose death rates or regional ones in Ontario. And we've watched them go from the national rate about 8 to 10 years ago is about 11 out of 100,000. And that's one of the sort of earmark frames we use is out of 100,000, what is the overdose death rate? It's not my favorite number, obviously, or my favorite calculation. But I was asked to go to Sarnia to provide some information to a community called the Kettle and Stony Point Indigenous community, which is just about 20 minutes up the road from Sarnia and about 50 minutes down the road from London, Ontario. So London, Ontario London, Ontario likes to talk about the fact that they pioneered the Safe Supply program. So there was a physician in London, Ontario who was providing hydromorphone tablets in around 2015, 2016 to mainly to women involved in the sex trade in the streets of London, Ontario, who needed to be brought in for better treatment of their HIV, their Hep C, their STIs, and so on, and to get them off the streets a little bit and link them to care. So the first I would have heard about that, I would have thought, that sounds like a good idea. That's a start. Bridging people who are really difficult to reach. We had tried a couple of things to find ways to reach street-involved women in Hamilton about 15 years ago, and it was really challenging. Like, how do we get them to come in for Pap tests and STI testing and so on? So that particular physician retired around 2015, 2016, and handed the practice down to her daughter's best friend, who took it over. And then that sort of took off, and we've all been experiencing some of the expansions of that program. But Sarnia has been dealing with, last year the death rate in Sarnia, the overdose death rate from opioids was somewhere around 35, which comes out to being 40 in 100,000. So that's quite a bit higher than any of the provincial numbers that we've looked at. So fast forward a few weeks later, I was invited to Sarnia, where the community itself, so the chief's daughter, who's an addiction and mental health manager in the community, want to decide for themselves how they're going to deliver addictions care. They want to decide what treatment means, but they do know that their trust is really low because they've left it up to the town of Sarnia to offer them what they thought was going to be good treatment, and they're not comfortable at all with it. Because really what's happened is that the tablet programs have sort of trickled along the road down from London, Ontario to Sarnia. So on one hand, we're looking at a community that's just down the road from all of these urban, I don't want to call them harm reduction because that's different, tablet programs that are expanding or have been expanding all over the country. On the other hand, a few weeks later, I was invited up to Fort Good Hope, which is where my picture is there, to participate in another community gathering. Again, this community gathering was held in what's called the Sawtooth region. Last year, all of the Northwest Territories, which isn't really designated there, but it's a massive area with probably, I think there's less than 30,000 people in the whole area. All of the Northwest Territories has had one of the lowest, and it continues to have one of the lowest rates of opioid overdose deaths in the country. Partly, there's lots of reasons for that. There's no one reason. Interestingly, the Yukon, which is just to the west of the Northwest Territories, has one of the highest overdose death rates, opioid overdose death rates. And they both have similar ways you can get there by plane or by road. So, and that's just a piece of information for now. So last year, all of the Northwest Territories had 3 opioid overdose deaths between January and September. Then in November, a little community just north of where my photo is there called Fort McPherson, which is in the Gwich'in territory, slightly north of the Sawtoo, experienced in basically one day, so in a few days, 5 overdose deaths, and I believe 8 people were poisoned, 3 were saved. Okay, so I was invited up there, and green one's not working. Oh, there we go. These are the kids who they'd never seen a naloxone kit, but they'd seen overdoses. So they'd seen people, this is in Fort Good Hope. That's me pulling out expired naloxone kits and letting them play around with them. Sorry. This is just to say that these kids haven't seen fentanyl yet. These communities haven't seen fentanyl yet, but they're starting to see it contaminating other things. So fentanyl is coming in, and the overdose deaths that occurred were contamination of crack cocaine, which is the most popular illicit drug up there. But these kids needed to learn how to use a naloxone kit, and they did. And I taught them how to teach other people to do it. But when we asked the community what they wanted complete control, just like Sarnia, over how they deliver care, what treatment looks like, and perhaps how to create treatment within their community and aftercare within their community. So all I really want to say, and this is the inside of their amazing church, which an elder, Lucy, whispered in my ear, told me it was unlocked and I could go in there and have a look at it before I left, which was great. It's quite incredible. What I really wanted to say is that the youth in these communities are recognizing, as they are starting to heal, they're starting to recognize that bringing the youth into talking about and developing their treatment programs, what it means to go out on the land, what it means to spend time with your elders has become really important. And I think that this is something that we need to be very mindful of, is that as we are creating programs for communities, we need to be really careful we're listening to what the communities want, because what we've heard is what we don't want to see in the cities, but we need to speak to each community to hear what they want in their little regions of the country. And that's all I really want to say. There we go. Oh, and 700 out of 100,000 was the overdose death rate in Fort Good Hope last year.
Thanks so much for sharing that. And thanks for moving through the comments quickly. And we're going to do that with the remaining speakers just so we can hear from everyone. Our next speaker is Peter Leach. Peter Leach is a member of the Titket Community Village of the Staktanik Tribal Nation, who specializes in working with Indigenous nations, communities and organizations, public and private sector companies, individuals, teams, and young adults in all aspects of life. And once again, there's a lot more in the bio that I encourage you all to read. Peter? Thanks, and thanks again for playing earlier.
Yeah, thanks. I'm going to pound my drum here. This drum is an extension of my heart. It's an extension of most Indigenous communities. That's why we use the drum. Like Bill had said, we drum for a purpose. And it even helps us as well. when we can sing, because it's comforting. And I'm probably like Bill, you know, I'm not as emotional, but I'm kind of upset and disappointed. I was asked out front there, somebody asked me when they seen my drum, who brought me here? Nobody brought me here. I told them, I said, the dead brought me here. That's who brought me here. Some of my family happened to be a part of that group of dead people. You know, and that's what I'm, you know, wanting to bring light to and pound my drum so that everybody can hear me. Because that's what I was taught to do as well. You know, like I said, my upbringing was from the Taliquid people in a place called Lillooet. That's where my father was from. My mother's from Musqueam, just across the water. Basically, technically, you're in my grandmother's backyard, and I'm welcome to speak here because of that. You know, and I take that very seriously. When we're talking about, you know, this crisis and how it impacts me, I've lost family members, literally, and I've lost brothers of late. I've been doing this type of work for good more than 25 years with my late brother, who passed away over a year ago, the late Gino Ojic. And a month later, I lost my younger brother, 52 years old. They were both 52 when they passed. And we'd done a lot of this work in a lot of different First Nations communities, you know, throughout the country. You know, but I look at the overdose, and I'm listening to a lot of people who, you know, share their thoughts, and I thank you for that, especially that one doctor who shared his videos. But I'm a common sense type guy. I don't like to play politics when it comes to people losing their lives. The bare reality is that my cousins, my brothers, they're dead now. They're dead. And they're not coming back. So what are we going to do about that? You know, I mean, you know, it's just, we have to talk about the common sense. For me, the common sense is what's the common denominator here, especially when it comes to fentanyl. And I haven't heard too much of it in here, and I know we're in a room with a lot of professionals and doctors and things like that, but for me, it's the pharmaceutical companies. You know, they created this mess. They honestly did. And they're not taking any responsibility for it. That's the bottom line. You know, I mean, no government official really, sure, they're going to bring them to court, and that's going to go for on and on and on. But I always say, I mean, especially when there's people in here that want to become the next premier of this province, what I follow is I follow a leader that's got courage. Courage to stand up and make a difference. Because we like it or not, we're at war here. That's why we pound our drum. That's why we sing. When we're ready to do battle too. You know? And that's, you know, I remember probably about a year and a half ago, they wanted me to come and do this presentation in Belgium for the World Health Organization. And I found out it was a pharmaceutical company that was going to sponsor me and pay me to do this work. And I'd asked, I said, do you guys produce fentanyl? And they said, yes, we do. And I said, well, no, I'm not going to attend. I'm sorry. I just don't want you supporting or sponsoring me. I'm sorry. They were even going to increase how much they were going to pay me by 3 times just so that I would attend. And I said, no. You know, I had to draw the line in a sense for myself personally that I can't attend, because I said, if you can stop making fentanyl, then I'll come and attend your event. But you can't do that, then I'm sorry, I can't attend your event. You know? Because that's what's killing us. We like it or not, especially when we hear the statistic of over 150 plus children. You know? The other thing that really needs to be understood is a majority of these individuals that are overdosing, probably we're looking at statistically, probably 80, 90% of them still happen to be indigenous people as well. That's the bare reality that we have to look at as well when we're talking about this. Those are my people. But we're all part of the human race. I mean, I'm Peter Leach. First and foremost, I'm a human being before I'm Statlium, before I'm indigenous. I'm a human being. It's my father's always taught me. You treat other people like human beings, you should never have a problem in life. You know, and I strongly believe that. Where the issue really comes from is you really got to understand what it is to be an indigenous person today and why our indigenous people are struggling the way they are struggling. I want you to imagine this. My grandmother, who died of cirrhosis of the liver, alcohol poisoning, at a very young age, because she couldn't overcome the loss of her sister at 11 years old, the loss of her cousin at 12 years old, who we're quite sure are part of those 205 kids in Kamloops. We're quite positive that they are. That was my grandmother's sister at 11 years old. And then people ask, why is your grandmother so screwed up? What's wrong with her? Well, you need to understand her. You need to understand indigenous people. That's what I always say. True reconciliation is understanding. And when we can develop a relationship, that's what I told Kevin when we first met. If you can understand me as much as I understand you, then we're off to a good relationship. And we're going to have a good relationship. But if our relationship's going to be one-sided, we're not going to have any success. And it truly has been one-sided for generations, especially when it comes to indigenous people. But I'm not one to stand up here and say, pity me, pity that. You know, I'm a little old Indian boy who grew up in the res. But today, I'm not your typical Indian anymore. I'm educated now. I own my own businesses now. You know? I never raised my kids on an Indian reserve. I did that for a purpose, because I knew it was what it was like to grow up on an Indian reserve. Not all reserves are bad, but they're all the same. The struggles of what they endured during residential school. You know, people ask, Jesus, how come you guys are labeled with alcoholism and drugs and things like that? You need to understand. I mean, I love using my father's story. And his book's going to come out next year, by the way. But I love using his story. You know, he went to residential school since he was probably 6, 7 years old. He did 1 year in Kamloops before he was transferred to Mission to be with the rest of his siblings. And the things that he endured and the things that he witnessed as a young child. I never heard his story until I was 27 years old. I was 27 when I finally heard his story. He never wanted to share it. But when he first shared it, we were in front of this tribunal thing, and they were recording it, and he wanted support. It's the first time I ever heard it. Bawled my eyes out. I finally understood, you know, what my father endured. I never went to residential school, but I consider myself a second-generation residential school victim for what he endured, what my parents endured, what the grandparents. and so on. But I think it's really time to go after, and I tell this to, and I call him Justin. I've known the Prime Minister ever since we were kids with the late George Manuel. I'm a protege of the late George Manuel. And if any of you don't know who that is, please look him up. I encourage you to, because he's the chief of chiefs. Union BC Indian Chiefs was created because of George Manuel. National Indian Brotherhood was created, which is now called the Assembly of First Nations, because of George Manuel. The World Indigenous Council, that document called UNDRIP, was created because of George Manuel. And I was his protege at such a young age, at 12, 13 years old. Why this guy believed in me at that age is beyond me, and took me under his wing with a few others like Wayne Christian and Stephen Point and the likes. But I have to, stand up here and tell you that we need to really go after what this is truly all about. And for me, who produces fentanyl? And I can harp on it all day. Is that we have to find a way, the courage, to have the courage. And I'm looking not at everybody in this room, I'm talking to the people outside this room. Especially when it comes to mental health, because that's what our people endure on a regular and daily basis, is the issues of mental health. And how do I know that? My brothers are a prime example, who both passed away. We can talk about it now because he's passed on, but the great Gino Wojcik had mental illness. He was bipolar. Same with my brother. Because their brains were damaged from the things that they did. My brother always used to tell Gino and I, when we go out to workshops with the young kids, tell them this: the decisions you make when you're young will seriously affect you when you get older. And he was a prime example. And that's the same thing that we look at as a society. The decisions we make now will seriously affect us 10, 20 years from now. And you know what? 10, 20 years ago, as a society, we screwed up. Because this is where we're at today. And if you don't think it's not a problem, and I know a lot of you think it is, or you wouldn't be here. But we screwed up years back. It's very evident today. And can we overcome this? You darn rights we can. It just takes time to understand. That's what it is truly about, is understanding. Especially when it comes to dealing with Indigenous people, which you guys are dealing with on a regular and daily basis in your lives of work. A lot of Indigenous people. And you know what screwed us up? We can thank, some people ask me, did the residential school work? Most elders would tell you, no, it didn't work. But I stand before you and tell you, yeah, it partly worked. It worked. Because a lot of our communities, a lot of our people are pretty screwed up, pretty angry, collectively. But if it takes us one Indigenous person at a time, one community at a time, that was our goal, was we're going to do it. If I spend the rest of my life trying to help, influence, and change an Indigenous person's life, I'll take the rest of my life to do it. But I know we're being filmed here as well, so if Justin is watching this, the ball is in his court. I'd call him Justin because I'm older than him too. But the ball is in his court with his government. Sorry, Justin, you may not even survive an election. Who knows? But I don't care, because I don't care who's the politician of the day. The bottom line is that you got to have the courage to do something and do it that's going to make a difference. Not just talk about it. You know, there's so much talk, no action. You know, I'm a little old Indian boy who grew up in the res. And I'm going to do it no matter what anybody says, one person at a time, one community at a time. I mean, I speak from experience as well. I've been clean and sober for 33 years. I was an addict. I mean, I'm just glad that I didn't take fentanyl when, or fentanyl wasn't really around when I was taking it. Oh, they prescribed me because, you know, I was fortunate enough to play professional sports in hockey, in soccer. I was a Canadian amateur boxing champ. Doesn't look like it today, you know, but athletics used to control my life. You know, I used to work out sometimes 2-3 times a day, me and my brothers. Of course, everybody knew my brother Gino, you know, but he battled with his demons. And he would do it all over again, without hesitation. But he had, you know, I mean, we can't be so hypocritical on prescription or pharmaceutical companies because we use prescription. I do. I mean, I had open heart surgery probably about 2 years ago. So I got to use prescription drugs for the rest of my life now, just to maintain. Well, my brother Gino used to take 5-6 Oxycontins a day, because his brain, his head, his whatever hurt. So much pain. And the same with my younger brother. But I thank Kevin and his team for allowing me to be here and allowing to share. You know, usually we talk about our wheel of fear that Gino and I used to do with a lot of our communities. I didn't bring the thing to put it up, but that's one of the programs that we use in a lot of our communities. We call the wheel of fear. It's a tool that helps you fix yourself. Like you need a tool to fix your car, you need a tool to fix your house. You know, we always tell the kids, if somebody comes up to you and says, I can fix you, well, run far, far away from them. You know? It's a tool to help you fix yourself, this wheel of fear. Worked for me, worked for Gino, and worked for many others. Because the common denominator of all our people, Indigenous people, especially if you listen to our elders, when it comes to residential school, is overwhelming fear. But we're doing some good stuff here. Sure, people are going to disagree with us from me walking in here earlier this morning, but we still got to do it. Collectively, we still got to do it. So I just wanted to thank everybody for allowing me to be here and listen to me, and especially share a song for my good brother Bill there earlier. And all I say in closing, if you really want to get to Indigenous people, and I know you're dealing with them on a regular and daily basis, is you got to take the time to understand. That's what you have to take the time to do. Understand. Listen to them to understand what makes them tick. So, thank you very much, and coach them.
Thank you very much, and thank you again for the drumming. Our next speaker is John Rustad. He is the MLA for the Nechako Lakes and the leader of the BC Conservative Party. As Minister of the Aboriginal Relations and Reconciliation, John signed more than 400 agreements with First Nations that have created economic opportunity for all British Columbians. John.
Thanks very much. And there's been a lot said. There's been a lot of presentations, some good information, I think, that has been shared. I'm going to be fairly brief, unfortunately, because I have to go and catch a flight, but I do want to make a few points, and I do appreciate the organizers giving me this opportunity to be able to say a few words today. You know, today as we speak here and we talk about this crisis that we have with the opioids, our Chief Medical Officer, Dr. Bonnie Henry, is in Ottawa talking to, I guess, a health committee, doubling down on safe supply and decriminalization. Now, I think there are things that have a place in our society, but I'm a firm believer that, you know, when something is not working, you have to really be taking a good solid look at it and think, what can we do different? You know, a family came and talked to me back a week or two ago, and they had 2 children. One was 14, one was 11, and both of them were suffering from addictions. So they thought, how do we get help? They managed to find a solution. They managed to find a private facility that cost them $20,000 for the first child, got them into the facility. Another $20,000 for the second child. They had to take out a second mortgage. But this is about their children. This is about their lives. This is about their future, which is why we're all here. The good news is they both now have come out of the facility clean. First one's already graduated, moving on. The second one is just graduating now. But why as a province, are we not providing that here? Why is it that we can't do that? Another business person I know, very successful business person, he was struggling with addictions for years. And they would book him to go into private facilities, and he would always travel down to them and then take off and go find drugs, time and time again. Finally, they actually had to book somebody to go with him and physically take him and get him into the facility. And he got clean, and now he's, of course, been many, many years clean and very successful as a business person. And I think about all those things, and I think, what do we need to do in British Columbia? And I think about the story that was just said, and thank you for sharing that story. When I was minister, I remember a chief who was in tears when he was signing an agreement. And I felt bad. I thought, you know, did we force you to do this? Like, what was going on? He said, no, you don't understand. 5 people that week in his nation had attempted suicide. 1 child, unfortunately, was successful. And the agreement, it was all about bringing hope, bringing an opportunity for people to think about a future that can be different, bringing about the opportunity to break the cycle. Economic reconciliation, a very important piece of true reconciliation. So I spoke with a number of hereditary chiefs just recently about this issue, and they said, we need to be able to have at least some opportunity within our nations to be able to start having change. Let's create some space. Let's bring in some services. Let's try to catch people before they go, and let's try to connect with people who have gone down to Vancouver and have found their way down to other communities who are in addictions, to be able to come home, to have culture as part of that healing, to have culture as part of that path. And that's something I thought about, and I think as a Conservative Party, we're going to support. It's something that needs to be done to be able to help First Nations through this. But this is an issue just for First Nations. There's many people suffering from these addictions. So we will bring an end to this idea of safe supply and decriminalization. Not because we want to turn it into a legal issue, because it's not. We don't want people arrested for simple possession or use, but because we need to make sure the police have the tools they need to be able to address this in our society. We need to make sure, for example, when you have cars coming and going from a house and police suspect it as being a dealer, that they have the ability to stop a car and seize the drugs and use it to go after the dealer and shut him down. That's been taken away under decriminalization. These are the types of things that we need to do. But of course, the big factor is recovery. In all of the steps that we talk about, what we want, I think, for everybody is the same thing the parents wanted for their children. To get people on a path to recovery, to be able to grow out and expand what we need to do as a society, to be compassionate, to be there to be able to help, and sometimes to have to be firm. So we want to take things like safe injection sites and make sure that they are recovery intake sites. Do everything we can to connect people to recovery, but we have to build out that capacity. We've got a situation in Victoria right now with the safe supply, or with decriminalization, I should say, a assisted living house for people that are challenged, that are homeless. They're in there. They've got special rooms for doing drugs. Of course, they go and they smoke fentanyl or they smoke crack. And they come out into the main area and they're still smoking. And the people working in that facility went to WCB and said, this is an unsafe environment for me. I want to be able to help these people. It's unsafe. And WCW, or the WorkSafe, I should say, said, you're going to have to wear a gas mask. These are the things that need to change. These same people that are in that facility that want to try to help these people would put up signs giving numbers and information about how to get to recovery. Those signs would be taken down by the ministry, and people were suspended for a day for doing that because they're worried about stigmatizing people. How do we get to this place? We've got to figure out how we are linking people to that recovery. We never need everything from doctor-prescribed treatment, and I really appreciate the doctors that spoke earlier and talked about their patients and the path and the journey that they're on. We need that doctor-prescribed treatment. We need to have voluntary recovery. We need to have voluntary long-term recovery, because many people, it's not just about getting over the addiction, but it's about how to build life skills. It's about how to support them, how to break the cycle of the people that they're in, how to get them being able to be reintegrated into society. We also need to, quite frankly, have mandatory treatment. Mandatory treatment is not a popular thing to talk about, but I look at it from this perspective. If somebody has OD'd and they've been brought back to life, surely under the Mental Health Act, you could make the case that this person is at risk of harming themselves. I think the compassionate thing to do is to get them into recovery, not get them back out onto the street to allow them to try overdose again. They clearly are calling out for help. Let's be there to do that. Let's build out what's needed. And I will say this, if we end up, quite frankly, with the court saying, no, you can't do that because you're taking away their rights, we need to use the notwithstanding clause. Because we need to be able to be compassionate and do the right decision for people in society. And that's a tough thing to do, to say, but we need it. We also need to make sure that we've got long-term care and recovery. There are some people today that have brain damage from these drugs. They will never be able to fully recover in our society. We need to be able to be compassionate and provide them with a service to the best of their ability to recover to a quality of life that they can. As a society, that's all we can do. The reality, when I talk to doctors, some of the doctors today, they tell me within 2 to 3 years of people on the street doing these street drugs today, it can be causing permanent brain damage. We cannot be facilitating to carry on with the addictions because the damage that's being done cannot be undone. We need desperately to get recovery. We need desperately to get a path for people to be able to come back in and to be able to lead as successful and as long-term lives as they can, being in our society, being in their community, being in their culture. Tough decisions that need to be made, but it is what we have to do as a society to break this chain. 7 people dying a day of addictions, of overdosing, is not acceptable. We have to be brave enough to say, no, we're going to go on a different path. We're going to build out that support, and that's what we're committed to doing. Thank you very much for an opportunity to say what your words today.
Our next speaker is Grant Denton. Grant has experienced life on the streets firsthand. Once homeless, a drug addict, and in and out of jail, he has learned valuable lessons about life and how to survive, and his experiences inform the projects he creates to help unsheltered people, and I'm sure he's going to tell you more about that as he comes up. Grant?
All right, breathe with me, people. This is my first symposium. I got a brand new suit. I'm not a policy guy. I'm a homeless advocate. I'm a programmer. I'm a person with lived experience. I'm going to share my story, and I'm going to share a portion of what happens before the recovery part of it when we're on the streets. My name is Grant Denton, and I'm the founder and executive director of the Karma Box Project. It's weird I have to read my stuff about me. I should already know this. We do free pantries in Reno. We operate emergency shelters, and we do homeless outreach and recovery programming. I was addicted to heroin and meth and homeless on the streets for 9 years. So I've been in this and working in this field for around 20. And there's 4 things that I know for sure. One is that when you're saving someone from drowning, they're not going to ask you who you voted for or who you prayed to. 2, drugs don't discriminate. They don't care if you're black, white, brown, rich, poor, pretty, ugly, male, female. Drugs do exactly what they're supposed to do. And 4 is homelessness isn't the problem. Homelessness is a symptom of a problem. Like I said, I was addicted to drugs and alcohol and homeless for 9 years. And eventually living this lifestyle, if you got $100 to $150 a day habit and you don't have any source of income, you might lean towards a criminal lifestyle. And eventually I violated probation and was facing 5 to 7 years in prison. Now, when you live this lifestyle, prison is actually a retirement plan. And so you're not really worried about that. You knew it was coming. It's part of the risk assessment. And during sentencing, instead of offering me just the 5 to 7, they offered me a drug court. They gave me an opportunity, if I wanted to go to treatment and then be involved in a drug court program. And if I failed at that, I'd still get the same time anyways, so it just made sense. So I accepted the drug court program. And in rehab, I had a paradigm shift. I could talk about that all day, but I did have a paradigm shift. We all know that, I know for sure that my drug addiction wasn't as much about drugs as it was an identity crisis. Every time I stopped using drugs, I was just Grant that stopped using drugs. I needed to reinvent myself, and the treatment program pulled me out of the element where I was able to find out who I was and learn a little bit more, and that it needed to be a longer process where I got released and went to a drug court program where they created a culture of accountability, where they held me accountable, just like in the real world. And so when I got out of rehab and I entered a drug court program, I was aggressive in my recovery as I was in my addiction. And I started to ask for a lot of mentors. I really wanted to succeed. I didn't want to fail. And I would see people in these programs. I would see folks in the programs do really well, right? Guys would pass all their drug tests. They would show up for all the groups. They managed to pay all their fines. And then when they graduated from drug court, they would go back to the streets. They would go back to using again. They would be back in prison. And I was panicking. I asked my mentor, I'm like, why is that? And she's like, well, it's because of their motivation. So right now, you're in fear motivation. It's the strongest motivation, but it only lasts as long as the threat. So when the threat of jail is gone, what's going to motivate you to stay sober? And then there's incentive motivation. That's carrot and string. But the carrot's got to get sweeter, and then the string's got to get shorter, and eventually you'll have to find a new carrot. But then there's growth motivation. And growth motivation is what's going to motivate you that's bigger than you, that's going to last longer, what's going to keep you sober and keep you thriving in life that's bigger than just this. And you have to figure it out when you're in your fear motivation. I was panicking because I had about 8 months left. 8 months of drug court, and I had to find this motivation, and I was looking everywhere for motivation. And I had a mentor tell me that it would be a good idea if I approached somebody who was close to me when I was in my addiction and ask them their version of my story, and sit down in front of them and let them tell me their version of my story without correcting them, even if I thought they were wrong. No, I didn't steal the van. It was the credit card. Even if I thought they were wrong, just let them tell me their version of my story, because that was real to them. And so I picked my mom. And my mom, in her story, told me her version of my overdose, my worst overdose. And my version of it was that I went to my homie B's house. I went to the bathroom. I shot up. Now, B didn't know I do drugs. She knew there was something wrong with me. Something is not right with this guy. She didn't know I was doing heroin. So I go to the bathroom, I shoot up. I wake up 4 days later in the hospital. I asked the nurse what happened. She said, you overdosed. I was like, oh, geez. And so I grabbed the phone and I called my mom. I was homeless, but I was going to call her for some money and to give me a ride. She doesn't answer the phone. And so I did like I always did when my mom didn't do what I wanted her to do, is I started to shame her. The worse my life got, the worse of the parent she was. I didn't take responsibility for my role in my life. And I started to shame her. I was like, well, you never answer the phone, Mom. If it was TJ or Wade or JP, you would answer the phone. You always abandoned me. Gotta be honest with you, Mom. Every character flaw that I have is a direct result of what a terrible mom you were. And I hung up the phone. And I got up and I took all the wires out of me. And within an hour, I was back behind Jerry's Nugget shooting up. That's my version of my overdose. My mom's version is different. She gets a call from my friend B, says the Grant overdose and he might not make it. My mom went to the hospital and waited there uncertain if her son's going to die or not for 3 days. Who has kids? Just imagine that. And I have kids. When she told me that, and then to get the call from me later, the next day, my mom said she didn't answer the phone because she knew I was going to ask for something. She was right. And she gets the call from me. And when she told me that, it's hard to see the picture when you're in the frame. And things like that will knock you right out of the frame. And so that was my growth motivation. I wanted to spend the rest of my life working with people like me and working with folks that were in my condition so that my mom would, and other people's moms would never have to suffer like that again. I understood the impact that I had on the world around me. It's crazy, is when we're drug addicts, we're like, we're just screwing our lives up. I don't know about that, man. Somebody loves you. Somebody's getting hurt. We're doing damage to not only the community, but to ourselves and others. We have a bigger impact than we think we do. And so I committed my life to working with folks like me. I guess you would say that I am a subject matter expert at homelessness and addiction, but I'm only a subject matter expert at my homelessness and addiction. If I want to be good at other people's, I have to actually work in this field. I have to immerse myself in it. So when I got out, I started working in sober living. I worked in treatment. I worked at a methadone clinic, and I worked at the homeless shelter. And then I created my own nonprofit called the Karma Box Project. And when I first started working in this Karma Box Project, it was me by myself, and I would work in homeless camps doing outreach. Now, outreach is interesting. Historically, outreach in a homeless camp would be you walk by with a flyer or a card and you're like, hey, call me when you're ready. Call me when you're ready. Call me when you're ready. And that's what we learned, is that's more like saying, throw this away from me. Throw this away from me. Throw this away from me. And you're not going to go to a homeless camp and stick your head in a guy's tent and say, hey, you ready to change your life, man? And him be like, yeah, let me just grab my stuff. It doesn't work like that. You have to build rapport. You have to build trust. And how do you do this? Well, you solve problems with people. And so I started to clean up trash. There's two issues in a homeless camp: behavioral and environmental. And the trash is a big deal. And so I would just get trash bags and I'd come out to the trash and I'd start helping guys. Hey, man, can I help you clean your tent? And they would start helping cleaning with me. And it got to where when I was coming back, they were cleaning up their own stuff. They're like, Grant, look at my tent, man. Is it nice? Do you like that? I'm like, yeah, man, you're doing great. And we started to build rapport, and then we started to get folks off of the streets, whether it was addiction. And let's say about 90% of our folks are substance users. A lot of them have mental health illness, but it's difficult to identify what your mental health is if you're still actively using, believe it or not. And so we made a really shocking discovery, is that all people aren't the same. And so we broke it down in the camp. So there's 4 types of folks that you're going to work with. You're going to work with the willing and able. Those are the guys that are ready. They're the easiest. They just need a hand up and a hand out. And they can still have the wherewithal to navigate a system. You have the unwilling and unable. Those are the severely mentally ill. That's another symposium. Then you have your able, but unwilling. And the able or unwilling are the guys that are service resistant. They're just living this lifestyle right now. They're very difficult to work with. And then you have your willing but unable. And what does that look like? Unable is they're mentally ill, physically disabled, substance use disorder, co-occurring, whatever that is. And this is mainly the group we work with. We've identified 4 constants when you're working with the homeless population, and we've identified the 3 ways to help. And up until this point, I believe we've been helping the wrong way when it comes to the help. There's 3 ways you can help a person that's homeless. You can help them stabilize, which is water when you're thirsty, jacket when you're cold, or you can help them survive. Survive, water, jacket, food. You can help them stabilize, which is getting someone into a house. You stabilize someone in a house. And then you can help them thrive, which is keep the house. The problem is if you introduce stabilize without introducing thrive, they're just going to lose the house. It's get the stuff, keep the stuff. And if you do this with somebody over the course of time, this is what we found is when somebody gets the house and loses the house, and then gets the house and loses the house, and then after a series of doing this over and over, it makes more sense for an individual to be successfully homeless than it does to suck at being housed. And we had a role in doing that if you don't introduce thrive. And then you go to the 4 constants of homelessness. Let me back up. How do you introduce thrive? Well, you have to look at the 4 constants of homelessness. 1, and this is, you talk to anybody that's on the streets, 1 is that you're subject to the elements. 2 is that your things will get stolen. That's how we shop. 3 is that you're subject to violence. That's how we resolve conflict. And 4 is that you're always on someone else's property. And these things all put you in a condition of fight or flight. There's 2 things you can't do at once. You can't protect yourself and grow. Because when you grow, you're exposing your underbelly and you're vulnerable. And you better not be vulnerable on the streets because now you're a mark and you will not survive. So how do you create a place of safety? Well, we opened up a safe camp. Safe camp. And where it eliminated a lot of those things, where we can help these folks grow. It's low barrier. But the thing is the problem in homelessness, there's 4 stages of homelessness, right? You have your unsheltered homelessness, you have your sheltered homelessness, you have your transitional homelessness, then you have your working poor. And each one needs a cultural adjustment. The problem, we get folks from the streets into the low barrier shelter, and they still have issues following rules. There's such a cultural adjustment. So what we did is we created a street etiquette card that we would hand out. We wanted to start working people on the streets, start adjusting people to actually following rules, to social norms. And if you ask anybody on the streets, I don't know if anybody works with homeless folks, you ask anybody on the streets, if you ask them, I'm like, hey, would you guys agree that maybe life is kind of crappy right now? Yeah, kind of sucks. Do you want it to be a little less crappy? And they're like, yeah. And I'm like, would you agree that these rules, if followed, could minimize life being crappy? And so we go, there's be discreet. Let's not crap on the sidewalks or in the wide open. Pack it in, pack it out, pack lightly so that you're not leaving that big of a footprint. This can also a stigma reduction model, because when we see homeless folks, we're like, they're messy folks. Well, kind of, but we don't have to be, right? So what if we packed light? You're always going to be on someone else's property. So if you're asked to move, man, you just got to move. And then, of course, throw your trash away. That is a QR code where I live at. So if anybody is ready to change, you just scan that QR code and it has a GPS map to wherever you're standing and every service provider around you. And it also has the link to their website so you can see the criteria to get in. And the last rule is my favorite rule. It should be the first. Don't be a dick. I had to put that in there. All right. And then eventually we move them into a camp. And when you get them into a camp, the idea is that you create a system that models a system you want them to succeed in. So when they're living in our camp, we have a standard of social norms in the camp. We teach them how to be cognizant of their footprint. We start working on how to communicate with people, how to be a good neighbor. We start working on pod guidelines. Like we want to take this pod and have it model an apartment. So when they do get their apartment, they're more likely to keep the apartment. The idea is that you use taxpayer dollars so that you can create taxpayers. This is a very, very difficult thing to do. It is not easy. I got a question. Who's ever tried to change their diet? Show of hands. How'd you do? That's just broccoli. We're talking about complex change. Complex change. It takes a lot of work. In a low barrier shelter, you don't have to be sober. You can't bring drugs on property, but you don't have to be sober. So how do you work with people that don't have to be sober? Well, you don't make it about the drugs, you make it about the behavior. For example, if the only thing that's required is you work on your housing plan. So if part of your housing plan is you get a job, I got to tell you, most people using meth can't keep a job. Most people doing heroin can't keep a job, or fentanyl, they can't keep a job. So if we keep getting the jobs and losing them, then that's an inability to stick to your housing plan. And so that gives us an opportunity to negotiate, use a little bit of tactical empathy. Like, hey man, would you like to eventually have your own apartment? Would you like to be out on your own? You're gonna have to get a job. Would you agree that maybe your job, your meth use is preventing you from getting a job? And this is what pushes us to getting folks into treatment. I think it's more successful for us to get somebody, an addict into treatment, than it is to get an addict into a house. And then, you do the dance as long as it takes. The dance is where you lead a little bit, and then they lead a little bit, and then you lead and they lead, and you do this as long as it takes, as long as you're making progress. What we found is some people do the dance forever. The second you stop making progress, you're part of the problem. You might have to pivot, right? Or come up with a different solution. This is just the programming part of it, and I just wanted to share that with you to show the complexities of working with folks that are on the streets. It took a lot of work to get me out, but I wanted to mention something that happened the other day because you guys are speaking a lot about it, and I just talked to Kevin a week ago, and when I was talking to him on the phone, it was 1 hour after I performed CPR on a guy that had just overdosed, and I was doing chest compressions for 12 minutes. I know this because when I called 911, I had the phone on and I had it next to me. We used 4 Narcans, sternum rubs, the whole gig. When the ambulance got there, he still had a pulse. I don't know if you ever given someone CPR before, but it's heavy because you don't know, and you feel it. And you don't know if this person's gonna make it or not. And when they took him away, he did have a pulse. And the next morning, and you lose sleep. If you want to be good at this, you better love people. Right? And if you love people, when people fail, you fail a little bit too. And when people die, you die a little bit too. The next morning, when I went to work, I saw Andy laying on the sidewalk. I was like, Andy, what's up, man? Dude, are you good, bro? He's like, yeah, I'm fine. It looks like he may have just got high. I'm like, brother, did they offer you treatment? He was like, no. I think that's a problem. I think maybe that was a missed opportunity. And you question, like, did I save Andy's life? Especially if he's right back out here getting high again. And you almost don't want to walk away from Andy because you think, like, what could happen? And I told him, I'm like, Andy, are you ready to go to treatment right now? He's like, no, man, I'm good. And I kind of worried at that second because if he would have said, yeah, would I have been ready? Would I have had to tell him to wait for 2 days or 3 days? And the problem is that often we're not ready. You keep telling someone, whatever you're ready, man. They're like, hey, I'm ready. And you're like, all right, 2 more days, you good? And it doesn't make sense. It's inefficient. We have, when you're living on the streets, can we agree that life might be traumatic? Little traumatic, right? And usually a cue for change is when something more traumatic than what you're used to happens, and an overdose is that cue for change. You have to use that. We've identified that there's people in our camps that will use Narcan 3 to 4 times a day sometimes. Overdose, get Narcan, and do this 3 to 4 times a day. So we put out these stickers, and I shared this with Andy when I was talking to him. We put out these stickers to share with folks that, like, every time you overdose, you die a little bit. There's damage done. And you might not be able to get that back, brother. You might not be able to get that back. And I asked Andy, on that QR code, there's you can scan it, and it's all the treatment centers, all the detox places. But this is all the damage that it does. And you might not be able to get that back. And And right now, in this moment, of course, like Andy's not thinking about that, but I think why we've gotten this bad and why we're not improving is mainly because we're lazy. We're just lazy. There's two approaches, right? There's the bootstraps approach, get a job and get off drugs. And then there's the love them till they figure it out approach. And I don't know if you've ever been in a bad relationship before. Bad relationships, anybody? Yeah, your heart did that. So you can't let your heart solve all the problems. It's not a good idea. You have to introduce logic and reason, and it's going to take a lot of work. I tell folks that I work with on the streets, do not succumb. It's a quote that I heard. It says, do not succumb to the soft bigotry of low expectations. I challenge you because I believe in you. I just want to close in saying that, like, I hear a lot of, when you look at both arguments, you hear a lot of folks saying, but we're saving lives. I don't think that saving lives is just CPR. I don't think that saving a life is just Narcan or just housing. Saving a life is getting somebody in a condition to where they'll never need your help again. Saving a life is living a life, helping someone get into a place where they can live a life free of addiction and the suffering that comes with it. Thank you.
Thank you so much, Grant. It's just really wonderful to have you here. Thank you for coming up from Sacramento and being a special guest of ours and the life-saving work you do. I also I want to introduce someone else who is doing incredible life-saving work and came from a similar area. We're moving the agenda around just a little bit so that he can catch his flight. But we really are honored, and it's so good to see still a full room. Thank you for staying. We have a couple chia puddings in the back for lunch, so hopefully you're on a diet. But we weren't expecting the numbers, to be honest with you. So this is a good problem to have as our PR, not our, but your Canada's PR comms guru, Jess Ketchum, would probably say, good problem to have when you have people sticking around and you run out of food and they're still here. Someone I'm very happy is still here right before his flight is a very dear friend of mine and just someone I've been particularly very lucky to learn from and to work alongside what Bob Dupont, who was the founding director of the National Institutes of Health, called us the Dream Team, which I'm not trying to congratulate myself. I think he was mainly speaking of Keith and our other colleague, Tom McClellan. But the three of us working together in the first year of the Obama administration, when, if you can imagine, in the United States, support for the president was 81% among all political parties, if you could ever believe it, that first year of that presidency. And it was really a very interesting time to be in Washington, a very different and very special time. And I was lucky and continue to be lucky to learn from Dr. Keith Humphreys, who's an endowed chair at Stanford University, who has done work for over 3 to 4 decades in the VA, working with veterans and hard-to-reach populations, and is one of those very few people who've not only published a zillion papers and is a incredible fixture at a university. They'll never let him go, but is someone that can speak to policymakers and do so effectively and actually implement the principles that they're researching. That's a very, very rare thing. So I'm really excited for Dr. Keith Humphreys to be joining us today. Thank you.
All right, I admire your endurance. Thank you, Kevin, for that very nice introduction. This was going to be the send you home speech, but instead it's going to be the run for the border speech for me. I'll tell you a story. When I was in college, I had a close friend whose father, unfortunately, was really seriously addicted to alcohol. And it blew the whole family apart, estranged him from his children, divorce, a lot of other problems. But in midlife, his dad had a rally. He pulled together 3 or 4 months of sobriety. After years of unemployment, he landed a terrific job. He started to get back in touch with his kids. It seemed like everything was going to turn around. And as sometimes happens, that was the moment that everything went bad. He relapsed. He got in a car in the interstate. He drove the wrong way. He hit a concrete barrier and he died. I went with my friend to the small town where the family had grown up in Ohio. And the preacher there had known them forever and knew about all the struggles and the ups and downs. And he said something that has stayed with me for 40 years, and it's this. In the face of things like this, our faith is sorely tested, yet it is precisely in the face of things like this that we need our faith the most. I am not a member of the clergy, but I am comfortable taking advice, good advice where it comes, so I'm going to take that religious advice and put it into the policy arena as follows. The experience of trying to make good drug policy has many parallels to the experience of addiction. There is pain, sadness, frustration, and setbacks, which can rob us of our hope that things can ever get better. But it's precisely in such situations where we must have hope that things can be better. So I thought in what was going to be the closing moments, I would just tell you 5 things that give me hope. And by that, I don't mean California, happy, clappy, naive hope. I mean realistic, hard-headed hope that those horrifying numbers that we saw during Kevin's talk are not destiny, that we can change that. So the first thing is this. No epidemic in the history of the world has ended by waiting for people to get sick and then trying to take care of them. That's not how COVID ended. That's not how HIV was brought under control. It's through prevention, stopping people from getting in trouble in the first place. We understand, the first thing that brings me optimism is we understand more than ever before how to help young people grow up healthy. And I don't just mean in avoiding drug use. I mean in succeeding in life and avoiding all the things parents worry about with their kids. The image of prevention that we have, and when I say prevention, I see this in people's eyes, is either a cop waving a billy club in the schools and talking about pot, or maybe a charismatic person who's in recovery giving a talk in junior high school. That's what people think of. But to think of that as the cutting edge of prevention is like thinking of the Tandy Radio Shack computer as the cutting edge of computing. That's what we did 30, 40 years ago. We have much more effective, wiser things today. I would really urge you to take a look at the site, Communities That Care. It's one word. The American government has it up. This is a developmental program for kids that invests in kids around the ages of 10, 11, and 12. And it helps them with generic capacities that help them avoid all kinds of problems. These are things like bonding with your school, bonding with pro-social adults, recognizing your emotions and learning how to manage them, learning how to cope with stressful situations. The studies you can see on this site with over 4,000 kids in them shows that not only do those investments reduce drug use initiation by about 1/3, and smoking by about 1/3, and alcohol use by about 1/3. But 10 years later, these kids are 20% more likely to go to college based on investments made when they were 10, 11, 12 years old. We have trouble sometimes getting the will to invest in prevention, but at least we know what to do, and that gives me hope. Second thing is we have a better understanding of the things that help people who are addicted get into recovery. Some of them are old. AA is almost 100 years old, incredibly. It helps a lot of people. Methadone is over 50 years old. It helps a lot of people. But it's not just that. There's a lot of exciting things going on. There's people developing apps and interventions, digital interventions that people can access anytime. There are medications in the pipeline. There are people using brain stimulation techniques, something called RTMS that I'm quite excited about. These things, as they come out into the world, are going to save more lives. As long as we are open to the idea that there are many pathways to recovery and there's lots of ways for people to get better, we will profit from that. So that is the second thing that makes me really optimistic. The third thing is we now have very good models that have been shown to work in lots of districts for the large group of people who will not seek help voluntarily, but are in the criminal justice system because they drank and drive, or they stole something, or they broke into someone's house, or they committed assault. And it doesn't have to be the kinds of things we used to do before, like throw people into a prison for years. So I think Kevin may have mentioned in his talk 24/7 sobriety, which starts in South Dakota. But that's an example of this. Or hope probation for people with stimulant drug problems. It transforms how the criminal justice system monitors people from slow, unpredictable, and harsh to something swift, certain, and fair. And swift, certain, and fair consequences change human behavior. In these programs, people are tested regularly, and they are given immediate consequences for use and for non-use. If you're in 24/7 sobriety, you're going to blow a breathalyzer every morning and every night. If it's negative, you get an immediate reward, another day of freedom. Even though you've drunk drive 3, 4, 5 times, you get to stay out. If it's positive, they're held overnight in a cell, just one night. Even though many of these folks have been in prisons, you think one night can't possibly matter. It does matter because it's completely predictable. They've done over 10 million tests in South Dakota with this program. The proportion of tests where this person has shown up and blown negative is 99.1%. This program is now spread through 12 different states. It has spread through England and Wales, and Blair Gibbs was a big part of that spreading through England and Wales. Just had interest in Australia. We need it in Canada, but again, we know what to do. We have ways that are therapeutic, and they actually make people live longer, don't fill up the prisons, and keep the public safe. The fourth thing is, I think reality is our friend. Reality makes an impression on people. It takes a while, but it does make an impression on people. So people who live entirely in an ideological world can recover. That's what I would say. So I look at what happens. We had the terrible murder of George Floyd and international appropriate outrage at the police brutality, particularly as directed towards African Americans. In my region of the country, from San Francisco, Portland, Seattle, for a few years, that got generalized into a sense that we didn't really want police to negotiate public space anymore. If a family wanted to go play in the park and the park was an open-air drug scene, the police were to not get involved. Or if there was a dealer on the corner, the police were not get involved. Or if there was somebody who was passed out on your stoop and you were trying to run a business and you were going bankrupt, the police would not get involved. That was worse than nothing. I would just say in the last 18 to 24 months, reality has made an impression on the people who believe that. And if you look at how they have voted and things like district attorney elections or the new things they're asking of police, I see a return to sanity. By sanity, I do not mean a war on drugs. I do not mean a carceral racist policy, but I do mean recognizing that public space is for all of us. People who use drugs matter. People who don't use drugs matter. And we have to sort that out, and sometimes we need law enforcement to do that. And it's remarkable to me, I go up to Oregon a lot, go up to Washington a lot, how many people say, I really thought this would work, but I changed my mind. And it's encouraging because we all know people, it seems like evidence can never sway them. But in this case, people were really swayed. They tried something different, it didn't work, and they actually changed their mind rather than just doubling down. So reality is our friend. It does make an impression on people. My fifth reason and my biggest reason is all of you. Beautiful day, beautiful city. You could have been anywhere else, but you're here. There's this expression, 90% of success is showing up, where you all showed up. And I know you're going to keep showing up. And I've talked to a number of people here who have worked for decades on this problem, and it's been inspirational to me. So I would say of all these causes of hope, the biggest one is the caliber and the compassion and the commitment of all of you. And I thank you for letting me spend a day with you.
Thank you so much, Keith. We really appreciate you being here, and we're very excited for that and that words of encouragement that I think will bring us through. We're also very excited for this panel, and actually we just kept adding people to the panel who had very important things to say, and that's the Citizens in Action, Neighborhoods Rallying for Success. Fran Yanor has started a publication, if you don't know about it, called Northern Beat. I invite you to check it out. She's a BC legislative correspondent, editor, and founder of Northern Beat, and has worked for many years in daily news, magazines, documentaries. She's going to be our moderator today, and we have really 4 very dynamic, wonderful panelists. The first is Colin Middleton of the Nanaimo Area Public Safety Association. He's the president and founder of that organization, and also the director of the board of the Center for Responsible Drug Policy, as a biologist, as a professional biologist, but really as a community member and a dad who really cares about this issue. We're also excited to join for Jenny Yang to join us, who's the co-founder of the Responsible Drug Learning Association in Richmond, which is an association, an organization, you can come up here, Jenny, dedicated to promoting education and prevention in drug policy, and focuses on a culturally sensitive approach to drug policy in British Columbia. Lynn Kennedy served 4 terms as a Vancouver City Councillor, where she took leadership roles in community safety, clean air initiatives, liquor licenses, urban planning, and heritage preservation, and has represented Vancouver at provincial and regional levels. And finally, I mentioned him earlier, Jess Ketchum. Jess Ketchum has advised industry and government on strategic communications and public affairs for over 30 years. He was basically the man behind Expo, the 86. His extensive community involvement includes also the chair of the BC Cancer Foundation, chair of BC's Wood First Committee, and recently as co-founder of a really just dynamic, incredible organization that has taken off called Save Our Streets. It's a coalition dedicated to raising awareness about crime and violence throughout BC and really catalyzing the community of really community members, but really business people. So we will do, I don't know if we have mics or how we're doing this exactly. Do we just have one of those and then maybe, okay, Fran can be at the, Fran can be at the podium and pass around. All right, Fran, take it away. Thank you so much.
That's one, too.
You look like you need a cold shower there, Kevin. Thank you, those that remain. So I'm just going to sort of briefly introduce everyone, and then we'll get to the panel. Starting left, ladies first. Lynn Kennedy. Lynn Kennedy was a high school teacher, a drug educator, and is still active as an archaeologist. She sat on police boards, liquor licensing, crime prevention, corrections committee, on and on and on it goes, and was a member of Canada's very first drug court board in Vancouver. They called her the Vice Queen. She was also, this is what we're going to talk about today, she was a Vancouver City Councillor in the early 2000s when it developed the precedent-setting drug policies that have since had hugely far-reaching effects on not just the city and the province, but the whole Canadian drug strategy. So depending on your perspective, they either transform Vancouver into a trailblazing harm reduction leader or into an example of what not to do with drug policy. Sure. Yeah.
Good afternoon. It's now afternoon. I'm your voice from the past. Here I am. So I was on City Council when Framework for Action at 4 Pillars approach came into being, and maybe if we'd done some things differently when we started, maybe we wouldn't be here today. We'd be out in the sunshine. Anyway, I could say lots about it, but I'm just going to say a couple of things because the time is short. So here's where I think perhaps we went off course. First of all, I'd like to say that Kevin was absolutely right. There were 4 pillars, but there really weren't 4 solid pillars. When we began in the early days of this, there was no equally balanced pillars. Not everything was the same, whether it was treatment or recovery or education and prevention and enforcement, or it was harm reduction. It was all about harm reduction when we started. And some of us who were on council tried to say perhaps we shouldn't start only with harm reduction until the other parts were in place. But our voices were shut down because apparently if we asked questions, you were in opposition, which wasn't true. Anyway, the mayor of Vancouver told us that we'd never have supervised injection sites unless they were happening at the same time in other cities across the country. Well, that didn't happen. So what did happen was we went out on it alone. And so there was never any kind of peer information, reviews or controls from any other cities in Vancouver. Everything was based on European models. And some of us had been to Europe, but some went to Frankfurt, some went to Amsterdam. I went to Liverpool to look at the methadone program. We went to Portland. We did look at things, but again, it came back to only harm reduction. And because we were the only city in Canada to launch this, we became a magnet with people coming, drawing users from all across the country. They heard about Vancouver and they came to Vancouver. So there was not much effort made to get community buy-in. We didn't really debate it publicly. We didn't talk about it a lot. And so many citizens just considered the downtown east side an anomaly. Perhaps they still do. Out of sight, out of mind. If you don't go down there, you won't think about it. But what was missing was the larger community voice. The voices of the large community were never heard. And the solutions were sometimes proposed or by the user groups or by the people who use drugs or by the groups and agencies that were serving those people. And those groups then became the voices that the press went to. So the larger community was never heard as to whether they thought this was a good idea or how it was working or how they could change it or how they could participate. So it became a divide. Another point I'd like to make was there were no audits made. There were continuing calls to have audits of the organizations that were involved in the downtown east side. We thought their funding base, their efficacy, and their outcomes should have been examined, and they weren't. And as Julian mentioned this morning, I was on drug court, and Julian was the person, and Simon Fraser came and evaluated drug court. And we were frightened at first and thought, oh my gosh, this will be terrible. They're going to come and examine all the things we're doing wrong. No, what they did was tell us all the things that we're doing right and how we could get better. And if audits had been done on agencies that were working in the downtown east side, I think things might have changed in the beginning, because the amounts of money that we heard that were being spent in the downtown east side were astronomical. They still are, the amount of money that's poured into the postal code. So we found and we felt perhaps that some of the agencies didn't really want their clients to get better, because if they did, they'd be out of a job. So if the question that Fran would have us ask at the end, and I'll answer mine now, is what would you have done differently? The one thing would be housing. Everybody talks about housing today. We need more kinds of housing, and it's been explained what kind we need. But one I'd like to address is dry housing in terms of treatment. So when you've gone through treatment and everyone's told us that we can recover and recovery can be done, you can't recover if you go to a building that is not alcohol and drug-free. And the SROs in Vancouver, we don't even really want to mention that. But I mean, where people went, it's so difficult to stop being an addict, as we've heard, and you have to work really hard at it. So when you're free to go somewhere after, you need somewhere safe and dry and sober. You need drug and alcohol-free housing. So in the beginning, the Salvation Army came to us and asked us if we could create some specific zoning so that they could have an apartment building beside their agency that was dry, that was drug and alcohol-free. We thought about it and we heard about it and thought that's a good idea. But unfortunately, instead of creating a specialized zoning area where it would have worked, people from COPE and Pivot came and said that if we did that they put pressure on us and they threatened legal threats to us and said they'd sue us if we did that. So it disappeared. So housing, and then later on BC Housing has put consumption rooms in all their buildings. So where you have consumption rooms, you're going to have dealers, because when you're consuming something, you need to get it. So that would be my one last point that I would have made, that we need dry housing. Okay.
Thank you, Lynn. Next is Jenny Yang. Sorry, Jenny was an auditor with Ernst & Young. She has a master's in public administration from Columbia. She has lived in New York City, Macau, mainland China, but it was Richmond where she attended her very first public protest when when residents pushed back against a safe consumption site proposed by a local city council. Citizens rallied, petitioned, and protest. Eventually, the health authority and eventually also the premier weighed in, and council paused the request. But at that point, then Jenny and her 3 co-founders formed Responsible Drug Learning Association to provide to local families what they thought was missing in schools, which was drug prevention education.
Thank you. I'm very honored to be here today, and I feel thankful to Dr. Kevin Sabage makes this possible. You know, we meet people from different groups, and we can talk with each other and to seek for real solutions for our drug problem. And to be honest, 6 months ago, I couldn't have imagined being here today to discuss drug policies, political protests. Everything began at this Richmond Council meeting on February 12th and the 13th. Over 20 years ago, Canada adopted a 4-pillar drug policy. In 2016, Canada recognized drug addiction as a disease. We all know the best way to fight any disease is prevention, right? Investing $1 in prevention, you can save thousands in harm reduction and recovery. And when not every disease can be prevented, addiction can. Ideally, in an ideal world, we should only need prevention. You know, save all the sufferings from disease and pain. And it's very interesting that, you know, Richmond, I don't know what's the percentage of attendance today from this area. So I live in Richmond, BC. And in our city, over 50% of the population, they're Asian, mostly East Asian. Oh, I'm so sorry. Don't worry about it. And we value family and education. When we saw teenagers smoking marijuana in streets, when we heard children claiming drugs are safe without knowing the risks, it's very clear to us the government's drug policy is failing. They're not doing enough in prevention. The situation worsened in this February when the most Richmond city councilors, they ignored the local voices and pushed through a motion for supervised consumption site in Richmond. And we realized that the government, they are not doing the right thing, and we cannot just watch. We had to step up. And that's how we founded our association, which is called the Responsible Learning Association, a Responsible Drug Learning Association. I mean, we are not professionals in this matter, but we want to learn, and we want to get the correct information, and we want to educate our kids so they can avoid this pain and suffering. And, you know, my 3 co-founders, they are math teacher and accountant and software engineer. They're not just the professionals, but also parents. When the government do not do their job and provide proper prevention education for us, we must act. Our children grew every day, and we cannot wait any longer. That's all I want to say for my introduction. Thank you.
Seems like there's some trends emerging here. Next is Jess Ketchum, president of Ketchum Communications, probably needs no introduction, but we'll give him one. He has worked with an outrageous number of top executives across the sectors in BC. He's also worked in and around provincial and federal politics since Pierre Elliott Trudeau and Bill Bennett. So many good stories there. I'm going to plumb in for. Originally from Quesnel, he's now in West Vancouver. He's co-founder of Save Our Streets, coalition of 100 community and business groups from every region across BC that came together very, very quickly. They're calling for reforms to curb crime and violence and to build a genuine, comprehensive system of mental health and addictions care.
Thanks very much, Fran. Let me first thank Kevin and his team for bringing us together today, organizing this opportunity. These discussions are incredibly important if we're ever going to find permanent solutions to these issues that are really tearing our families and communities apart. I noticed before when Kevin Falcon and John Rustad were here that I was very nervous about being between the two of them and keeping them apart, so I'm glad they've left. There's a lot of people that have been trying to pull them together recently. I've been involved quite a lot with those guys. Crime and violence has led to the deterioration of our communities. Over half of British Columbians live in fear of being victims of crime. Over half. People's pride in their communities and their towns is deteriorating. It's taking a beating because of the open criminal activities and the open suffering of people impacted by addiction and mental illnesses. Families are having to restrict their activities within their own neighborhoods. Businesses are closing. Family supporting jobs are being lost. Downtowns are running the risk of becoming ghost towns. Fran mentioned that over 100 organizations have come together in the Save Our Streets coalition. I can tell you that these are business organizations from the largest organizations in the province. I'm pleased to see that Laura Jones she's the CEO of the Business Council of BC, has spent the day with us here so far today. We have organizations that have sprung up in these communities, like those represented by Colin and Karen and Kevin that I see here today as well, who have come together because of these issues. So it's business organizations and community organizations who are concerned about one thing, the state of their communities. And while today's event is focused on drug policies, SOS, Save Our Streets, is focused on crime and violence regardless of the causation. We're advocating for greater adherence to, that good old thing, the rule of law. We thought there should be more attention to that. We are advocating for not only judicial but prosecutorial reform and support for police services so that they can help keep us protected. However, we recognize that a significant segment of the crime and violence being experienced in our communities has at its core addiction and mental illnesses. If we as a society were to encourage our governments to adequately care for those sick among us, much of that crime and violence would be eliminated. So SOS is advocating for governments to establish a comprehensive continuum of care incorporating diagnosis, detox, treatment, and long-term recovery that we've heard so much about today, but also based on prevention, a solid foundation of prevention. And I'm pleased that we've heard about prevention, not only from our panel this morning, but also from Dr. Humphreys earlier. I don't think we talked about prevention and what that consists of nearly enough. So we need to be able to ensure that people, if they are suffering from addictions to mental health, can get treatment when they need it and where they need it. We want governments. Everyone has stories of how people cannot get in to detox, or how they can't transition from detox into treatment in time for them to avoid relapsing over and over and over again. We all have those stories. Some of us, I do, have family members that have gone through that, and it's really been driven home to me just how important that is. So we want governments to lay out a plan where those services are located today, but also where new services have to be introduced, how many detox, how many treatment, how many recovery facilities do we need, and where do we need them? I was very pleased to hear Kevin Falcon this morning talk about how we needed to replicate the Redfish facility. He mentioned 5 times. Well, that's the first time I've heard anyone say that's how many we need. I don't know if that's the case or not. I think we need to have that conversation, but it's through sessions like this that we'll start to understand why we need them, where we need them, and how quickly we need them. The unfortunate thing is he's in opposition. You can only make those decisions when you're in government. So, the important thing to me is that having Kevin and others talking about establishing those facilities where they're needed around the province will influence government. And so whoever is in government has the opportunity to lay that out. But we want to know how many detox facilities are required, how many treatment facilities are there required, what form and how many recovery services are required, and where, and just as importantly, when. Lay out the plan so that we can hold government accountable. I know that's kind of strange, but hold government accountable for establishing these things. Because today, quite frankly, you can go through all the reports, you can go through all the government's websites, and you won't find that. And we need to be able to make sure that's established. So, being able to measure demand along with measuring progress on establishing those services to meet that demand is critical. You can't manage what you can't measure. I really do believe that. And surely, we don't want the sole measurement to be the number of people unnecessarily losing their lives. Thank you.
Last but certainly not least, Colin Middleton, professional environmental scientist. Colin and his family moved to Nanaimo 3 years ago, not realizing they settled within a few blocks of the busiest safe supply dispensing pharmacy in the city. Within a year, he found the first of dozens of discarded prescription labels. And then he noticed drug dealers, public drug use, chaos, dangerous streets, essentially. He co-founded the Nanaimo Area Public Safety Association initially to alert, public health, local authorities, BC government of the dire situation, and then discovered not so much interest as he had hoped. He soon realized the problem was systemic, not just the neighborhood or the city, the province, maybe the country. Anyways, he now advocates for public safety and drug policy reform.
All right, thanks for that. Okay. Thanks, Karen. Yeah, it's important for me to acknowledge that I'm standing on the shoulders of others' community-organized efforts in Nanaimo that began following the dismantling of Discontent City in Nanaimo, one of Canada's largest ever homeless encampments, and the subsequent establishment of a SRO, single room occupancy housing, BC housing project in a residential neighborhood in 2018. So that's we have the Newcastle Community Association and the Victoria Crescent Business Association, who really laid the groundwork for what has morphed into the Nanaimo Area Public Safety Association. I'm not an expert in addictions or professional health services by any means. I'm here on my day off from my environmental consulting job, which is why I'm underdressed. But I do feel compelled to be here and to do this advocacy work as a Canadian citizen and as a father and someone with experience in scientific pragmatism that I think we need more of when it comes to our current public health and safety emergency. You know, it's supposed to be the province that does what our group is doing, which is raising awareness of public health and safety hazards to proactively keep its people safe and productive members of society. We believe that at its core, the public safety emergency we are experiencing in BC is the net outcome of three overlapping cultural and institutional crises: mental health and addictions, affordability and housing, and justice system and law enforcement. We assert that the public at large is bearing the burden of the consequences from ineffective leadership, lack of transparency, evasion of accountability, and the abdication of responsibility by senior elected officials and public servants. All of that burden is being downloaded on the public at large, and we're fed up. Thank you.
Can you stay there? I'm going to ask.
Sure.
So something Colin told me, because I have interviewed him before, is a story he told me. When he first started finding the discarded prescription labels, he went to the pharmacy and he said to the pharmacist, "Hey, there's all these labels on the ground. Did you know that? I think they're being trafficked. Like, it looks like people are selling their drugs." And what did the pharmacist say?
Oh, well, I mean, at first the pharmacist said, "Oh, well, no, that's not what's happening. They're not right in their minds, so they're just peeling off the labels and throwing them on the ground because they don't know where the garbage can is or whatever." I mean, there's garbage cans right outside. But I mean, it didn't take much conversation for him to at least admit that, you know, it's possible that that's one of the things that are happening. But, you know, the next thing they said was, "Well, you know, it's not us. We're just the dispensing pharmacy. You need to go talk to the clinic downstairs. They're the ones that are doing the prescriptions, and there's nothing we can do."
And then you went to the college?
I have gone to the College of Pharmacists, and as of today, they are not returning my emails.
And then you went to the health authority?
And after one or two emails back and forth, they are no longer returning my emails. And we have submitted freedom of information requests through our association. We have paid fees to obtain documentation on contracts from Island Health to nonprofit organizations that are responsible for prescribing and administering a lot of the drugs that we see coming out of the building there. And that was back in November, and as of today, we have not received one lick of it.
What about the provincial government?
The provincial government, we received canned responses for a while. There was one email that I did receive in response to concerns raised about diversion 8 months after the fact, sometime in 2023, which was essentially just a promotion of all the things that they are doing, and thanking me for my concern. And since then, I no longer receive any canned responses.
Is that good or bad? I don't know.
It's really bad. No, it's really bad. Like the trying to get real information as a citizen out of the provincial government is almost impossible. And that lack of transparency is causing a lot of problems. And when I say, like, the lack of transparency itself, there's that adage, you know, in the absence of facts, people make up stories. Well, there's a lot of stories right now because there's no facts coming out. And anything that does come out is all spun to serve a political narrative. Even the information that we do get out of the health authorities are so watered down and broad brush that it's not useful. So we've had to try to reconstruct things ourselves.
So thank you, Colin. And so the common thread there. So Jess, what kind of response have you had from government? That about sums it up.
That pretty much does sum it up. But in fairness, government's response has been very quiet. They talk about the things they have done, but they seem to refuse, to us at least, seem to refuse to establish data points upon which they can be measured. And it's serious when I talk about you can't manage what you can't measure. I really believe that. And if we were to have data points that said, look, here's the demand. We have so many people in British Columbia that are addicted, or so many people that are suffering from mental illness, then you can establish what facilities and how many and where do we need to respond to that problem. And that's why I say there's no plan laid out that establishes that we need so many facilities in the Lower Mainland, Southern Vancouver Island, the major metropolitan areas or major urban areas around the province, Prince George, Kamloops, Kelowna. How many facilities are required there to meet that demand? That's not out there. So what we're advocating for is to lay that out. We find that government has resisted doing that, and we may have to do that ourselves, using experts, using some of the people that are here today, professionals, to say, okay, based on the demand, here's the types of facilities we require or services, and here's where we require them. And by the way, here's when we require them. And then we can then measure government and their performance at delivering upon that need.
Thanks. Actually, the city of Dawson Creek, did you hear? They're actually stepping up to buy the primary care center in their area because they realize that people, obviously their citizens need access to doctors. So just in healthcare, I mean, there's all these solutions stepping up in the vacuum. I just want to go back to Jenny for a second. When there's a lot of protests, as we all know, they're kind of all over the place, seem to be a lot of them well organized. Now, Jenny, in Richmond, they had one protest was like 400, a second protest was over 1,000 people. But you were, okay, so there's two things here. So you were accused of NIMBYism, and I'd like to hear, like, you maybe tell people sort of what your impression was also of the media coverage.
That's a very sharp and good question. I have to say it's unfair to call them NIMBYs. They're not, they're least, I think they're the least political people I could see in this world, you know. They probably cannot speak fluent English, some of them, because this is an immigrant community. But most of them, they are nurses, teachers, and they are hardworking taxpayers, raising the next generation of Canadians. Their voices deserve to be heard, but they're underrepresented at the city council. And when they pushed through the motion, they didn't really listen to their voices. And their voices deserve to be heard. And it's unfair that they do not have a say in what's going on in their neighborhoods. And they are so worried, concerned about the safety of the neighborhoods. And they love this country. They sacrifice mostly for their kids. They sacrifice a lot to live here and to bring up their children. They should have a say when their children's safety are in danger. I think that when the council say they are misinformed, then why didn't they pause the voting and provide the correct information and give the time necessary for the public to digest that information? I think that's fair, and I think that's democracy.
I'm pretty sure we're over, so I'm going to leave the last answer to Lynn. Going to throw one at you, Lynn. So what we hear is government's not listening. It wasn't set up properly from the beginning. Everyone wants the 4 pillars. In different communities, they're all stepping up to try and provide the 4 pillars. What is the solution? What needs to happen? And, like, I know this is a big one, sorry, but for government, what is the solution? Is it every community rising up, or?
Well, I think what we heard today, we heard that there are solutions there. And I heard the word recovery probably used more often than I've heard in a long time. Because it just hasn't been in our vocabulary. We've talked about so many other alternatives, and the word fulcrum is too. So for communities, I really think that they need to be sure they follow the 4 pillars. And as you pointed out, Fran, 4 pillars wasn't a word that we used 25 years ago or 30 years ago. It was Brian Mulroney's government that used 4 pillars. So it's been around the concept, and of course in Europe it's based and stuff too. So I think whatever you try to do for hope and recovery, you have pillars. They need to be equal. That was our mistake. That things weren't in place before you started projects, and none of us were particularly close to insight, but we were close to finding out that there weren't alternatives and there were places for people to go afterwards. But as Lucia said in Dawson's Creek, they're, getting their own space and then making sure there's place for people. That will make a difference. But I think it was the concept is good. The implementation was not good. The other thing I should say is the mistake we made, I think, all those years ago, was hiring a director who had absolutely no knowledge or medical expertise and not much knowledge to give them. So if you're going to have someone oversee your plan in terms of community, you need to have a professional. And the other thing is, I do believe you need to get community support. And today we heard people have never been so angry, but it's not a way to get community support. People who sort of held back and thought, well, it's not my problem, it's not in my neighborhood, and I'm going to look at it. Okay. They're now affected by it. I mean, every family we've heard, how it's affected public at large. So we need to talk more, we need to communicate more, and that's why I'll be heard. And Peter, with their comment today, meaning that how the birth means state, but it means state listening. So, yeah.
Thank you. Just one fun fact to build on that is I was doing some research of the Canadian drug policy, from it first began, and it had a lot of roots beyond Mulroney, but Mulroney's government, surprisingly, was the first to mention 4 pillars, and they, as far as I could tell in terms of the research papers done on it, they since then have the one that actually weighted the resources across the 4 pillars most equitably, which was a surprise to me.
Well, thank you so much, Fran and Jenny, Colin, Lynn, Jess. Really appreciate those perspectives. Look, I think I think we're all in agreement that this could be a week-long conference, or at least 3 days. But we wanted to start small with 4 hours. We went closer to 5. I appreciate you all being here. I hope you felt it was worthwhile. This is the beginning, though, and we do want to have discussions and dialogues. We want to bring people together. We want to bring people that may not agree together and find common ground. We want to come up with real solutions, actually, and promote those solutions. We want to talk about the different impacts. There were so many other impacts that we didn't even get to talk about today. What are the impacts not only on individuals but on systems, on industries, on specifically different communities? I mean, we could go on and on. we tried to touch on just a small sampling of each of those things, and I'm not sure we were successful, but I'm very proud of the organizing team here that really worked so hard to put this on with basically no resources and no funding. We are going to be, fundraising, so you should know that. And if you happen to know any billionaire friends, let us know. But in reality, though, we really will count on your support, both in every kind of way. So follow us on Twitter, or X, I guess it's now called. Follow us there. You can take a picture of the QR code. It's just prosper_CA. And then we'll be sending out a evaluation form to try and learn, so that we could learn more about sort of what your thoughts are for the future on this. So actually, and we already have it up, so we will send it out, but if you want to take a picture of it, please do. But if you're registered with Eventbrite, you will get an email from us, and with your consent on our email list. And so there's so many people to thank. Will Jones did an incredible job as MC. I want to thank Will. I want to thank Luke Niferatos, the co-founder of the Foundation for Drug Policy Solutions. I want to really thank all the neighbors we worked with, the business people, many of whom couldn't even be here because they had other engagements, but they wrote checks to support, the food, or to support, whatever else we needed. We want to give a heartfelt thanks to the Wall Center that donated the space to us, and we're sort of that the case where it's always the people that don't pay that cause the most trouble, because we were originally supposed to be, of course, as you all know, downtown, and then we had to scramble. We also want to thank the whole Wall Center, but specifically also the security, the catering, and the event planning here at the facility. Really did a tremendous job, I think, and they did an amazing job. So you will hear from us. This is the very beginning, and again, thank you all for coming today. Thank you.